to the last and final day of workshop and the happy Teachers' Day to all, and happy Eid also. So with this last day, we will start with the this lecture session. For this, the chairperson is Dr. Naveen Arora, sir. So Dr. Vijay is on way from airport. So for the time, I'm starting with my lecture, one of the lecture, that is role of mucolytics in respiratory disease, and I'm going to tell about what is the role of these mucolytics in the respiratory disease in the next 15 to 20 minutes. So look at the airway mucosa and the mucosal characteristics in disease compared to the healthy among the asthma, COPD and cystic fibrosis. There is increase in mucin, there is increase in plasma protein, inflammatory cells predominantly increase in cystic fibrosis, and DNA, and again actin is again more in the cystic fibrosis, and then COPD, then asthma. In infection with bacteria are again common with cystic fibrosis and COPD. So what the exact pathological changes occur in this disease in the in proximal and the peripheral airway disease? So here is submucosal gland enlargement and goblet set metaplasia that leads to neutrophil and lymphocytic infiltrate, and airway epithelial hyperplasia and ciliary dysfunction, and hypertrophy and smooth muscles and connective tissue. In the peripheral, the diameter of less than 2 mm diameter, there is increased number of macrophages and lymphocytes, increase in the B lymphoid follicles and fibroblasts, luminal and inflammatory exudate, and the extensive goblet cell metaplasia in the bronchial fibrosis and narrowing. So what this hypersecretion leads, and what the impact on the COPD, that leads to decline in the lung function, decrease in the quality of life, and it's increased the acute exacerbation and hospitalization, ultimately leads to the increased mortality. So what is the impact of this hypersecretion in COPD? That's cause progressive decline in lung function. The study of more than 12-year follow-up study with nearly 4,000 patients, including nearly 2,000 and 2,000 females, reveals that the chronic Phlegm is declining the FEV1 by 4.5 ml per year. Then it is associated with significant risk of acute exacerbation and hospitalization, 2.4 times in women and 2.6 times in male. Another larger study of more than 8,000 patients found that there is a significantly increase of Phlegm, increase of death risk, that is male by 3.7 times, in women 11 times. So what we have the option available for this airway clearance, we have both pharmacological and non-pharmacologicals. Among the pharmacological, we have mucolytics, expectorant, mucoregulatory agent, while in the non-pharmacological, exercise, positioning, drainage, positive expiratory devices and oscillatory devices. So these are the management how we do for the airway clearance, for proximal, cough augmentation, flow acceleration, wall oscillatory devices. For peripheral, there is a positive expiratory pressure, breathing exercise including autogenic drainage and active cycle breathing, and conventional like manual technique and the positioning. So among the pharmacological option, we have expectorant. This expectoration cause hydration and increase the volume of the secretion, that's including hypertonic saline, guaifenesin and ambroxol. Then classical mucolytics, this hydrolyze the disulfide bond of the mucous protein and decrease its viscosity. They are N-acetylcysteine and endostin. Then peptide mucolytics that degrade the DNA and F-actin polymerase in sputum, like donafus alpha, thromycin beta. Then mucoregulatory agents that are anti-inflammatory and inhibit the mucus secretion, like steroid, macrolides and anticholinergics. Then mucokinetics, which increase the mucociliary clearance, are the bronchodilator and surfactant. So what the pure mucolytics, the three are carbocysteine, N-acetylcysteine, and iodostine. The mechanism of action of these is it's reduce the mucolytic activity by reducing viscosity, reduce the bronchial secretion, increase mucociliary clearance. Then antioxidant activity leads to pro-oxidant profile and reduce the pro-oxidant profile and increase antioxidant profile. Anti-inflammatory activities reduce neurogenic inflammation, cytokine release, protein synthase, and reduce level of pro-inflammatory drugs. Direct and indirect bacterial activity, including the killing activity, bacteriostatic, reduce bacterial adhesion, biofilm reduce, improve antibiotic activity, and viral replication. So coming to some of the study on the mucolytics in the COPD, this was a review published in 2010, and this review found that the mucolytics therapy reduced the exacerbation and the numbers of disability and are well tolerated, and the numbers of adverse events are lower than placebo. However, at that time there was not this was not clear that underlying mechanism in which phenotype of COPD benefiting from the mucolytics agent. Then a meta-analysis was published in 2015 to clarify role of N-acetylcysteine, including 13 studies with more than 4,000 patients, and the study shows that the diamond is in the favor of treatment with N-acetylcysteine, and the result found that the treatment with N-acetylcysteine reduced frequency of exacerbation, which is statistically significant. In the study concluding that this study leads to state that COPD patient with airway obstruction, N-acetylcysteine should be administered at the dosage of 1,200 mg per day to prevent exacerbation, while patient suffering from chronic bronchitis but without obstruction, regular treatment of 600 mg per day seems to be sufficient. Finally, since the effectiveness of N-acetylcysteine at higher dose is slow and progressive, prolonged and regular treatment might be in necessity for the prevent exacerbation. Then in 2017, another review and meta-analysis was published for the effect of carbocysteine. Here 4 studies involving more than 1,300 patients was included in this meta-analysis. In the meta-analysis of these 4 studies again found its favor in the treatment with carbocysteine compared to the placebo. They found there is a decrease in the risk of total number of exacerbation, significant, also improve quality of life, reduce the numbers of patients with at least one exacerbation compared with placebo. The study concluded use of carbocysteine 500 mg 3 times a day may be associated with lower exacerbation rate, similar number of patients with at least one exacerbation, and higher quality of life in the patient with COPD. Then Indostine is effective mucolytics and antioxidant, anti-inflammatory and antibacterial properties. It reduces the viscosity of mucus and the purulence of sputum by mucolytics, antioxidant, antibacterial and anti-inflammatory action. So the study way back in 2010, again the meta-analysis was done for 15 studies with more than 1,000 patients with treatment of standard plus 300 mg of iodostine twice daily or placebo given for 10 days. And they evaluate for the cumulative global efficacy index, sum of all assessed respiratory sputum score such as cough frequency, intensity, viscosity, difficult to expectorate, rhonchi at the auscultation, and dyspnea, and overall the physician efficacy assessment. The data found that the iodostine is the treatment is favor compared to placebo, as well as the iodostine is more effective than other mucolytics treatment. And the study concluded that the treatment with iodostine is associated with significant benefit in terms of symptoms amelioration, both versus placebo and other mucolytics in chronic bronchitis and COPD patient. Then another study was meta-analysis was done in 2018. Again, more than 10 RCTs with more than 1,200 patients. Here adenosine 300 milligram BD or TDS or 350 BD versus placebo for the 1 year, 52 weeks. Then they calculate evaluate the breathlessness sputum cough scale, cumulative global efficacy index, non-specific clinical score, physician global assessment disease severity, and the subject global assessment disease score, risk of exacerbation, time per fast exacerbation, duration of exacerbation, and the risk of hospitalization. The study again favored in the treatment group compared to the placebo. Some of the parameters are more effective in COPD and 2 of the parameters are more effective in the chronic bronchitis groups. And the findings show adenosine is able to improve the clinical score of patient with chronic bronchitis and COPD. They found that it reduced the risk by the COPD exacerbation by 35%. At least one chronic bronchitis exacerbation by 29%, and they also increase the fast time exacerbation, prolong it, reduce the duration of exacerbation, and also reduce the risk of hospitalization by 46%. They support the use of adenosine as an add-on therapy for prevent COPD exacerbation when administered with frequent exacerbators. Then this restored study was published in 2017. It is a randomized blind placebo controlled study of 467 stable COPD patients, adenosine 300 BD or placebo to usual COPD patient for 12 months. They evaluate the outcome was number of exacerbation during the 12 months, and the secondary outcome are duration of exacerbation and time to fast exacerbation. It is found that it reduced the exacerbation by nearly 20% and the reduction in the mild exacerbation by 57%. So this is showing in this one. And there is, however, there is no difference was observed in the rate of moderate to severe exacerbation. However, it also showed decrease in the exacerbation duration irrespective of the severity by 24%. Only 10% of adenosine related treatment patient versus 37 patient treated with placebo needs increased use of reliever medication. That is also clinically significant. And concluded that the adenosine prevent exacerbation and shorten their duration irrespective of whether inhaled corticosteroid is given. However, the availability of well-tolerated, simply administered orally active treatment like adenosine should be valued to patients who experience these troublesome episodes. Then a Dalpy consensus was done in 2010 from 53 experts from 12 countries on all the 3 mucolytics agent for the Dalpy consensus. And on basis of this, they grade it into strongly disagree to strongly agree from 1 to 5. And on basis of this, based upon this availability data, chronic use of mucolytics at the standard dose is effective in reducing the COPD exacerbation. The score is very high for the adenosine with grade 4 and 5 in nearly 80%, more than 80, while it is nearly 40 in the carbocysteine and less than 40 in N-acetylcysteine. Similarly, if they are asked for the regular mucolytics can be reduced the duration of mild to moderate exacerbation, again the high score is for adenosine in nearly more than 80%, and here N-acetylcysteine in nearly 40, and the least with carbocysteine in nearly 30%. The data from the meta-analysis clinical trial with mucolytics support their efficacy in reducing the risk of hospitalization. Again, score is very high for adenosine, more than 80. Again, N-acetylcysteine second with the 40%, and carbocysteine least with nearly 20%. Then, is there any significant evidences available for recommendation of regular use of mucolytics? Then again, the adenosine score the highest, nearly 80%, slightly lower than 80, N-acetylcysteine for more than 40, and carbocysteine least within less than 40. So, findings from this Dalpy study suggest that the wider use of mucolytics agent aids on therapy for COPD is considering, especially in patients with less severe airflow obstruction, as the beneficial effect on the exacerbation may contribute towards slowing the disease of the progression. Then this study, again a meta-analysis of comparing all the three drugs, mucolytics agent, including 7 RCTs, and they found that the mucolytics agent all are effective compared to the placebo. Amongst the mucolytic, edostein is more effective than other two. And they found that mucolytics agent significantly reduce the risk of acute exacerbation. Only edostein reduce the risk of experiencing at least one exacerbation, a risk of hospitalization due to exacerbation. Edostein and N-acetylcysteine both significantly reduce the duration of exacerbation also. They concluded that the overall efficacy and safety of edostein is superior to the both of the carbostein and N-acetylcysteine. Further, while head-to-head studies need to perform on the same population group are defined, confirm the results. So coming to the guideline, the COPD guideline, goal guideline in 2025, from 2024 itself, the regular treatment of mucolytics such as carbostein and N-acetylcysteine may reduce the exacerbation and improve the health status, while edostein may significantly affect in mild type of exacerbation who are on the ICS. So the according to this the maintenance medication of COPD goal 25, all the three are mentioned, that is edostein, carbostein and N-acetylcysteine, while the advantages of edostein is the dosage is 12 hourly. Then coming further, this evidence for this treatment, the regular treatment of mucolytics, edostein, carbostein and N-acetylcysteine reduce the exacerbation in selected group of patients with the evidence B. These are the good. So I am summarizing with these. Mucus hypersecretion can cause progressive decline in lung function and increased risk of exacerbation and hospitalization in COPD patient. The commonly available mucolytic drug are carbocysteine, N-acetylcysteine and edostein. Treatment with these mucolytics decrease the exacerbation and duration of exacerbation. No head-to-head trial is available till date. Studies have showed that the efficacy and safety of edostein is slightly superior to the other two. Gold guideline recommended to treat the mucolytics within evidence B. Thank you very much.
Yeah, thank you, Sonam. If there are any questions regarding this one, the COPD, you know, it's going to increasing because maybe because of the pollution which you are looking at, means everybody is inhaling everywhere which is there.
I have not gone through any study which in this, sir.
How long can we continue?
The guideline has not recommended it yet, but we can safely give it for 3 to 6 months. I already shown those who had lower lung function test, frequent exacerbation may benefit better than those without.
Okay, and time duration is not recommended at all?
Not recommended yet, may it come. Earlier in the 2024, the dose are also not recommended for other two, except this edostein. So year by year with the evidence, we may get in the next guideline.
Thank you, sir.
Thank you, Sonam. Now we may call Dr. Vidushi Rathi for a talk on role of nasal filters and allergic covers in respiratory allergy. She is an assistant professor at VPCI. She has MD in pulmonology medicine, DM in pulmonology criticals from AIIMS Delhi. She is a fellowship in sleep medicine. She had European diploma in respiratory medicine, and she has got Dr. S.N. Gord Young Scientist Award in EP 121, and she had approximately 50 publications in various national and international journals. And this is stage to you.
Thank you, sir. Thank you for the kind introduction. Hello, everyone. So today on the last day, we will be discussing on the role of nasal filters and allergic covers in respiratory allergy. So we have already, So we have already covered a bit about it. We have had a lecture on allergen avoidance. We're just focusing a bit on the nasal filters and allergic covers that might come to you from because these things are available to the patients over the counter. They might ask you directly about them. So what are you going to tell them about it? Whether it is useful, beneficial, and does it have any scientific basis? So let's go on to the physiological basis that there's a respiratory epithelium that has a function to have the movement of whatever comes in the air. The air has particles in it and your epithelium has the protective functions. When it becomes compromised, there's activation of the immune system. So allergens and microbial organisms can lead to that. We have all seen that in various talks, and this leads to development of chronic inflammation. So the concept is if you protect this, if your barrier is compromised and you're protecting it, maybe you would reduce the inflammation. So allergen avoidance is required. Now we have common allergens of these sizes. Why are these sizes important? Because our nose can filter out a lot of these, majority of these. In fact, PM 2.5, anything above 2.5 is mostly prevented by the nose. What we are focusing here is such as pollen and spores. So pollens are the larger ones, 10 to 100 micron, while house dust mites are the smaller ones, up to 10 microns. Let's first come to the nasal filters. What are nasal filters? They are disposable or easily reusable devices that you insert into the nose, in the nares, and it has a combination of mechanical and electrostatic filtration. So as the air passes, the larger particles get mechanically trapped and some of the smaller ones, the holes are not 100 micron or 10 micron small, but because of the electrostatic charge, they get trapped. And there's a balance. The air flow is also allowed. So air flows in, the patient has to breathe in comfortably, but because of this charge, the particles get trapped. Now the filter shape is modified. People have different sizes and shapes of nose, so they have to be modified for the nostril shape, and there are various versions for the same. There are certain nasal filters in the market. You can see various types. It has been more commonly available in the Western market, but these are available in India. Most of the time you can see on websites. And the price is sometimes acceptable. So this is something around 300, and these are disposable ones. There are some reusable ones also. And they claim that PM 2.5 particles also are 95% efficiently removed. So your pollens would be included in that, and even many milder, smaller spores would also be removed. What does the literature say about this? So you have some studies on pollens. This was from Europe, a small study but randomized double-blind placebo-controlled trial of 46 patients with rhinitis symptoms on exposure to ragweed and grass pollen in this season. Nasal filters they used for 2 hours, and they found that sneezing, runny nose decreased, itchy eyes also, watery eyes, itchy throat, all these symptoms decreased. What did not get decreased was blocked nose or postnasal drip. So significant improvement was seen, and there was another study, again a smaller study of 65 patients, and they found that nasal filters were well tolerated and no serious adverse events were recorded, and many patients when asked, they said they could continue using it. So patients who are symptomatic with rhinitis have said they have been comfortable to use it. Now mind you, these are small studies. And based on this, this was a little larger study. This is an open label study to assess whether the 1,073 patients of seasonal allergic rhinitis, they were used, and of the 834 new users, 630 stated that they would be interested in continuing using these filters. So what are the pros and cons? Pros is it's compact, easy to use, portable, it's a discreet option. It is not very clearly visible if seen from a distance. What is the disadvantage? It is difficult to use with a very runny nose. It might get blocked with the runny nose a lot. Although they say that the runny nose is decreasing, but it might be more uncomfortable. And a prolonged use may not be comfortable, and where you have a very high pollution burden, we do not know how it will be affected. Maybe it will get blocked earlier. There are something like combination devices now being considered, and this is in advance, that along with the nasal filter, they deliver the drug. So the filter would act as the first line of defense, and simultaneously a medication would be delivered. So maybe this might come in and people may have a better efficiency of use. Eventually you will have to choose, because these particle sizes can also be blocked by simple surgical mask also, or N95 masks. Now the thing is, what is the patient's preference? If they want not a mask is not to be used, they want something which is more acceptable to the general public, then they can consider it, and there is some evidence to its use. So that's about nasal filters. Now let's come to anti-allergic covers. That is, specifically we are talking about covers over mattresses and pillowcases for house dust mites. So avoidance measures in house dust mites are physical barriers, removing carpets, upholstered furniture, humidity control, acaricides, and combination of these. In the physical barriers, as we had discussed earlier, sir had also told you about those polyurethane covers were also used at some time, but they were quite uncomfortable. So gradually things improved, and now we have finely woven covers with variable pore size. So the pore size enables air and water to go in and out, so that patient is comfortable, but the woven nature prevents the allergen escape. So it is effective and comfortable. So this is the kind of mattress. They are zipper locked. They have a safety steam, and the mites are not allowed to go in. You can see these are the non-woven fibers. So A, B, C, D, this is loosely woven, so the dust mites move about. Non-woven cover, acaricide coated, but non-woven, and again non-woven. So you have mites molting in the non-woven ones, but these tightly woven fibers, which are systemized regular fibers, there the mites are not able to escape out of the mattress. So you have some things available even in India, but the cost is substantial. So when you ask a patient to use this, you have to be careful. You are asking something like this, and this substantial cost, how much benefit is it going to give to them? So you have some studies. In 2008, we had a systematic review of house dust mite control measures of 54 trials, 3,002 patients, of which 36 trials actually only covered the physical methods. What did they conclude? No effect of intervention, no statistically significant difference in number of patients improved asthma symptom scores or medication, and that's why they said that it could not be recommended. But the other guidelines also said that allergen avoidance is not recommended, physical methods might reduce the allergen burden, but what is its clinical benefit, they are not clear. But just because something does not have a clear evidence of benefit does not mean it doesn't work. Okay? Just failure to demonstrate benefit doesn't exclude its efficiency, and in contrast to most studies in adults, the studies in children has actually shown a positive impact of the avoidance strategies. So you had many studies in children, such as all of these, and among these the largest is the Morgan et al. Study of 937 patients, where a multifaceted approach targeting multiple allergens, including physical barriers, vacuum cleaner with HEPA filter, they had a significant reduction in asthma symptoms. So the GINA 2024 did say that while encasing bedding in impermeable covers has reduction in allergen levels, but clinical benefits, while in adults it is none, children it is some benefit. And similarly, it has also said for fungi, the remediation of dampness is important. So while they are not recommending it in GINA, they do agree that there is some degree of reduction in allergen levels. Now, individualized assessment may have to be done. This is the most recent article that I could get. It was a review of house dust mite allergen avoidance, a hypothesis generating meta-analysis. They did different kinds of combination control. One was partial bedroom control, where maximum 2 interventions. One was fitting of mite impermeable covers with washing bedding monthly with hot water. If 1 or 2 of these was used, it was partial bedroom control. Total bedroom control, both of these with removal of carpet, cleaning of soft toys and other textiles. This was total bedroom control. And there was a study assessing the air purification also. Portable units placed randomly or in the breathing zone. What did they find? That 90% reduction in mite load was achieved by a combination of 3 bedroom interventions. That is this, fitting of mite impermeable covers through all bedding, washing bedding with hot water, and cleaning of the room with carpet, removing of carpet and soft toys cleaning. Also, nocturnal air purification of the breathing zone also decreased the asthma symptom scores. But this is also again from smaller studies, single center studies, and further studies are required. So to take home, you should consider that nasal filters, if somebody asks you, yes, it can reduce pollen exposure, may be helpful in controlling AR. Whether the person uses it or not depends on their comfort and convenience. Anti-allergic covers, they do reduce the mite burden, but on their own, they are not very effective strategies, but may be helpful in some patients with combination. Some better results have been seen in children. Cost-benefit ratio has to be done for individual patients. Okay, thank you. If there are any questions, I would take them.
Ma'am, any question?
What, sir? Sir, mostly that I could find on net was one-time use, disposable ones, but they are available. The studies have been also done on reusable ones. They can be washed simply and reused. But the single ones, I think, are definitely cheaper options available. I could not find any study that says reduction in the efficacy of the anti-allergic covers. No, generally these things have a manufacturer guideline that how long these can be used, that kind of thing, but no such study. And for practical purposes, if you see, if you have young kids, you might be using those dry sheets. Practically seeing, they would also be impermeable and they are comfortable to use under your sheets. All of us who have young children have used them. Maybe we could try, stitch it up, make a zipper out of it, encase the whole bed mattress in both of that, and how it would function, we do not know. But it might be much cheaper than this allergic cover option.
Is there, so if you feel that there is a need of giving this, you can use the plastic sheets also. I have recommended some of the patients and really works. So plastic sheets, you can on the mattress put the plastic sheets, but the problem with the plastic sheets that when you sleep, there is a discomfort with the sound of the plastic sheet when you move here and there. So how to take care of that? So what you can do, put the plastic sheet, and after the plastic sheet, you put 2 or 3 bed sheets, so that discomfort will go and the patient will be fine. So these are some of the remedies can be done. It's very, very important that you should get the proper anti-allergic covers, whatever she has told, Ovenman and all those things. So generally we don't get it. I think one of the manufacturer who is importing from Malaysia, they are only working towards south. This side nobody is working, so we are asking them also to come to this part of country also. Very good, Vidushi.
Thank you, sir.
Thank you, Vidushi. So moving to the next lecture is on the role of biologics in asthma management. For this, we have Dr. Siddharth Raj Yadav. Dr. Siddharth is associate professor in the department in this institute only, and he has more the n numbers of publication in various national and international publication, and he will going to talk on the role of biologics. Over to you, Dr. Siddharth.
Thank you, sir. Thank you for the introduction. So good morning all, and my role today would be to speak on the role of biologicals in asthma management. And you all must be thinking, what is this biological? And it is usually used in the bigger centers or the centers which are the apex places. So one thing I would like to make very clear, you all must have used biologicals in your life for sure, because it's a molecule of any size and origin or cell that specially targets the critical physiobiological mechanisms in order to gain therapeutic advantage. And you all have used recombinant therapeutic proteins, vaccines, I'm quite sure you must have used, blood and blood components you must have used in your ICUs, in your wards. So it is not a thing that you cannot use. So there shouldn't be any inertia over it that biologicals is a big thing. So today we are talking the role of biologicals in asthma, and mind you, the definition of asthma, as much as it has evolved over a period of times, no other definitions have evolved, because there is a paradigm shift in understanding the asthma from a single disease to much more chronic disease, and which marked clinical heterogeneity. And moreover, after the concept of asthma syndrome, which was coined by Gwen, it has become much more complex. So he states that asthma syndrome has got various domains, which is the clinical domain, physiologic domain, and pathological domain. And these domains may coexist, but may be unrelenting to each other. And the basic building blocks or understanding of asthma is now based on the phenotypes, which are the observable characteristics, and each phenotype may further have more of the endotypes, which are the biological mechanisms. And each phenotype may share more than one endotype, and an endotype may be present in more than one of the phenotypes. So things become quite complex. So I'm not going in depth of the definition and not repeating it, that already has been repeated by previous presenters. So now coming to the severe asthma, its prevalence and its burden, because these biologicals are being used in severe asthmatic patients. So it is very important to understand what is severe asthma. So severe asthmatics are the patient who require high dose of inhaled corticosteroid plus a second controller or an oral corticosteroid to prevent it from becoming uncontrolled or remains uncontrolled despite this treatment. So to make things much more simpler for you, just see in your OPD cards if a patient is requiring ICS and a second controller, high dose ICS and a second controller, and in the previous year's OPD cards, you find that more than 50% of times the patient is being given oral corticosteroid. Yes, he can be labeled as severe asthmatic, but important point here is again is, don't make all difficult asthma patients severe asthma patients. Try to look for the conditions which are actually leading to severe asthma. So its burden, why it is such a burden? Because it uses almost 50% of the resources. It reduces the quality of life. There is high risk of having severe back conditions, which again leads to increased resources and more of the hospital admissions, and frequent reliance on oral corticosteroids, and which leads to secondary complications. And I can vouch for that. If we just start taking the complications, what all complications we have from oral corticosteroids, we can all name one here, right from our hairs up till our nails in our toes. So overall, it has been estimated that nearly 5 to 10% of the total population of asthma patients suffer from severe asthma. So hence, it is quite an important aspect. So now coming to GINA 2025, and what does it say about the treatment of these severe asthmatics? So it clearly says that in track 1 as well as in track 2 of control and reliever, the updated guidelines say that phenotype-based assessment should be done and biologicals should be assessed as a controller. And OCS is only used as an additional controller. And moreover, to bring things more further, they have said OCS should be used only as the last resort. But in real life, what happens if you look at your own OPD cards and you just have a look over it over a period of years, you can see that most of our patients who are coming to our OPDs are receiving oral corticosteroids on regular basis. And in real world evidence have shown that nearly 42 to 64% of severe asthmatics actually receive oral corticosteroids. So that's a huge burden again. So now coming to the next diagram, it's a very important diagram which actually lends at the pathways where biologicals can be used. So what happens here when environmental factors such as allergen, viruses, and irritants interact with the airway epithelium, it leads to release of mediators. Mediators such as TSLP, IL-33, IL-25, and these allergens are further taken up by the dendritic cells, which further present them to the T cells. And this leads to a further cascade of inflammatory pathways leading to cytokines such as IL-5, IL-4, IL-13, and which are further taken up to B cells and which leads to release of IgE, further leading to bronchial enlargement, basement membrane thickening, droplet cell hyperplasia, spoon bubble contractibility, and leading to symptoms of asthma. So here what is the thing important? That here what you see in the red are the pathways for which biologicals have been approved and biologicals can block it, leading to a blockage in with this inflammatory cascade. So the ones in the red are the ones which are being approved, and the ones in the green are which are in the pipeline. So now coming to the Indian scenario, as in today in Indian scenario, we only have 3 biologicals which are available. That is the omalizumab, mepolizumab, and bentralizumab. And amongst all these 3 biologicals, only omalizumab is the one which has been approved for the pediatric population. Though in America by FDA, mepolizumab as well as bentralizumab have been approved in pediatric population, but yes, in India still we have not received the DGCI confirmation for it. So now we'll be discussing each of these biological in depth. So first and foremost, the biological which we have used the most and from the oldest time is the omalizumab. It is a monoclonal anti-IgE antibody. It binds to the circulating IgE and prevents the binding to its receptor. It reduces bronchoconstriction on allergy exposure and reduces sputum eosinophilia. So now coming to few of the trials which we are going to discuss is the first and the foremost trial of omalizumab was the INNOVATE trial, which was a landmark trial. And in this INNOVATE trial, what it was found when used omalizumab as compared to placebo, there was a exacerbation reduction rate by almost 26% and improvement in FE1 by 94 ml, which was significant. There was 56% reduction in the emergency department visits and hospitalization rates, and there was improvement in the quality of life of asthma patients. Now coming to one of the Cochrane reviews of omalizumab, in which 25 trials were included, and Cochrane review is considered as the gold standard, and it was seen that it was done to see the efficacy of subcutaneous anti-IgE as an adjunct to treatment to corticosteroids. And what was found in this Cochrane review was that omalizumab as compared to placebo reduces asthma exacerbations by approximately hovering 25%, reduces hospitalization, and allowed reduction ICS dosage. So it is a win-win situation, all conditions in it, that you have lesser exacerbations, reduced hospitalization, you're saving money, and reduced doses of ICS, reducing the overall complications caused by corticosteroids. So now coming to the indication where it is to be used in asthma patient. It is to be used in asthma patients who are more than 6 years of age, who have had multiple exacerbation despite high dose of ICS and LABA. And a very important point to consider here is that the patient should have a positive skin prick test or specific IgE against perennial aeroallergens. And this is the point which we usually miss. That is a very important consideration. Only in this subset of patients you will be having a very good response. Now coming to the dosage chart. The dosage of this molecule depends on your pre-treatment serum IgE level and your body weight at that time. So you have to find out what is your pre-treatment IgE level and what is your body weight. And according to this chart, you can decide what will be your dosage. So say if the IgE level is 700 to 800 and your weight is around 25 kg, so your dose will be somewhere around 225 mg. So that is important. And other important part here is that when your dosage is more than 300, so you get a pre-filled vials of syringes of it. So at one site, you can only administer 150 mg. So and if you want to give 300 mg, then the other dose has to be given on the other arm. That is a very important consideration. Now coming to monitoring. Now monitoring is again very important, and most of us see that, feel and see, and it is much obvious that you are giving an anti-IgE treatment, so IgE levels should fall and you'll start monitoring the IgE levels of the patient. But that is the wrong scenario. You shouldn't do it, because actually when you start giving omalizumab, the serum IgE levels will increase due to the formation of IgE and omalizumab complexes. The treatment should be continued at least for 24 weeks to look for a response. So initially just by giving one dose, you won't have a response. And when you start giving this treatment, the patient should be monitored for the first 2 hours for the first 3 visits in your clinic, and thereafter 30 minutes after that. And the adverse effect with it is very important. There's a black box warning of anaphylaxis in 0.1 to 0.2% of patients. So it should be administered in clinic, though clearance for home administration has also come recently. Now coming to the second biological which I'm going to speak is mepolizumab. Mepolizumab is also a monoclonal antibody directed against IL-5. It's bind to the free circulating IL-5 and prevents it binding to its receptors. It was approved in 2015 November in US and in 2015 December in Europe. So now coming to the few of the trials of mepolizumab, the first and foremost and the landmark trial was the Messner trial, which was used in mepolizumab as treatment in patients with severe eosinophilic asthmatic patients. So here in this trial, what was done, that mepolizumab was given as 100 mg subcutaneously and mepolizumab 75 mg intravenously in 2 arms, and was compared to placebo, and it was found that there was an exacerbation reduction rate by almost 53%. There was a significant improvement in FE1 right from the 4th week itself, and by the end of the 32nd week, there was an improvement of 98 ml, which was significant. There were hospital admissions was reduced by 61%. There was improvement in asthma control, and there was clinically significant improvement in SGRQ scores also. So if it is so good an improvement, what is its role in the glucocorticoid sparing effect? That study was done, and the study was called the CIRRUS trial. And it was found that in the CIRRUS trial, the glucocorticoid dosage in comparison to placebo reduced by a whopping 50% by the end of the 24th week. And the secondary endpoints on this study is also found that the rate of exacerbation also reduced in this study also in comparison to placebo by almost 32%. And asthma control improvement score was improved right from the 2nd week itself. So it started acting right from the 2nd week in the asthma control improvement scores. So if it is so good in all these studies, can it be used for a long term? So for that, a Cosmos trial was taken, which was an open label trial in which the patients of Messner, which was total of 576, and CIRRUS 135, both placebo and the treatment arm were taken into Cosmos trial, and they were seen for the serious adverse effects over a longer period of time. So in the Cosmos trial, it was found that total of 558 adverse effects were reported, but the most common adverse effect which was seen was nasopharyngitis, which was on approximately around 30% of the patients. In serious adverse effects, it was found that only asthma exacerbations was there, which was significant, which was almost in 6% of patients. Other serious adverse effects such as pneumonia, bronchitis, appendicitis, and other was less than in 1% of the patients. And important finding here was that it continued its response. Mepolizumab continued its response in Cosmos trial. Even the patients who were on placebo had improvement. So the findings supported that long-term use of mepolizumab can be considered. So if it is so good in all these trials, what does it do in the real life? For the real life, to evaluate it, a retrospective analysis was done in 138 patients in Italy who were given mepolizumab for 1 year. And it was found that the blood eosinophil counts, the mean range decreased from 822 with a standard deviation 491 to 117. And exacerbation decreased by almost 81%, which was significant. And the dose of oral corticosteroid also decreased by 28%, which was significant. So in real life setting also, mepolizumab did work. But in this study, what I found, what I thought, that instead of mean, they would have took median, it would have been a more meaningful answer because standard deviation is quite high. So we need to look at further things. So what is the indication and dosage? So it is indicated as prominent in India in people who are 12 years or older, who have eosinophilic asthma, who are unresponsive to GINA 4 and 5 therapies, and the absolute eosinophil count should be between 150 to 300. The dosage is 100 mg subcutaneously and is given once every 4th weekly. And coming to the mepolizumab adverse effects, which I've already told you, but an important thing later in few studies, it was found that patients who were more than 50 years of age had episodes of herpes zoster. Hence, vaccination with varicella vaccine is a very important consideration when giving mepolizumab to people who are more than 50 years of age. So that is to be remembered. Now coming to the next biological which I'll be speaking is the benrolizumab, and benrolizumab was made by Astra by hybridization technique, and it's a very unique molecule because it acts like a double-edged sword. So what it does, that benrolizumab with its Fab fragment attaches to the IL-5 receptor of the eosinophil and prevents the binding of IL-5 on it. Whereas with this Fab fragment, it attaches to FcFR alpha segment of the NK cells, which lead to release of granulozymes and porphyrins, leading to eosinophilic apoptosis by its unique method of antibody-dependent cell-mediated cytotoxicity. So by both ways it works and reduces your eosinophil count. Now coming to the trials and to the efficacy of pembrolizumab, Sirocco trial was done initially, which is a landmark trial, and this is Sirocco trial what was done, which was carried out for 48 weeks. In this trial, the patients were divided into groups. Patients with eosinophil count more than 300 and eosinophil count less than 300. And in each group, the pembrolizumab was given in 2 different regimes, a 8th weekly regime and 4th weekly regime with a dosage of 30 mg. So it was found that the patients who had eosinophil counts more than 300 and who were given by the regime of 4 weekly or 8 weekly, there was significant reduction in the annual rate of asthma exacerbations, whereas patients who had eosinophil count less than 300 and who were given by a regime of 8 weekly did not have a significant reduction, though reduction was there, but it wasn't significant. So the secondary endpoints in this trial was to look at the FEV1 levels and asthma symptom scores, and it was found that patients who had eosinophil count more than 300 had improvement in their FEV1 levels and as well as in their ACQ scores. So just similar to the Sirocco trial was the Calumet trial, and it was a little longer trial of 56 weeks. And it was found in this trial that patient either having eosinophil count more than 300 or having less than 300, all the groups of patients had significant improvement in their asthma exacerbation rates. And the secondary endpoints were also similar, and there was improvement in FEV1 as well as in their asthma symptom scores. Now coming to it, that what is its effects in glucocorticoid sparing? And here also in this trial, it was found that whether given 8th weekly, whether given 4th weekly, it had almost 75% dose reduction of OCS in the pembrolizumab group. So it does reduce the oral corticosteroids. Now coming to the meta-analysis, and what did the meta-analysis of almost 1,951 patients which was identified and done? It was found that pembrolizumab can be safely used in to improve FEV1. It can improve the quality of life, reduces the asthmatic exacerbation, improves the ACQ-6 scores. So, and a dosage which was considered effective in this meta-analysis was 30 mg 8th weekly, which is the optimal dose that has been considered. So now coming, can it be used for long term? For long term, other trials were done, such as Beltami trials, which was taken up to 5 years, and it was found that it's quite safe. And the most common side effects were the nasopharyngitis and worsening of asthma and URTI. And it can be well tolerated. So if it is so good, what does it do in the real world? In real world, a recent article had come, and they had found that when you give pembrolizumab for a long period of time, and what response criteria they have kept in this study was the response reduction. That response rate was if there is a reduction in 50% of annual exacerbations, 50% reduction in the mean oral corticosteroids, it was a good response. Super response was considered if there was zero exacerbation and no oral corticosteroids at all. And this study, it was found that total of 130 patients were taken, and they were treated for 48 weeks. Out of this 130 patients, 72% had reduction in the annual exacerbation rate. 57% were exacerbation free out of it. And looking at the OCS sparing effect, out of 130 patients, 74 patients were on oral corticosteroids with the median, and it was found that the median dosage decreased from 10 to almost 0, and 38 patients out of this 78 almost totally discontinued the oral corticosteroid. And the major part of the study was 51 patients out of this 130 were super responders. So no exacerbation, and oral corticosteroids completely stopped. So what are the indication dosage? Again, 12 years and above, unresponsive to step 4, step 5 of GINA. But important thing is, AEC level, absolute count should be more than 300, and dosage is 30 mg subcutaneously, 4th weekly for first 3 doses, followed by 8th weekly subsequently. So other biologicals which are currently available world over are reslizumab, dupilumab, tezepelumab, and this tezepelumab will be coming soon to India, and it will be a game changer. It will act on both the eosinophilic as well as non-eosinophilic and T2 high, T2 low asthma patients. So now coming to algorithm, that how to select the biologicals. So once you have made sure that yes, the patient is of severe uncontrolled asthma, then look, that patient has atopy, if his serum Ig levels is raised or not. If it is raised, we can consider omalizumab. If it's not the scenario or patient has a increased or eosinophil count, we can consider mepolizumab, benrolizumab. If patient has high phenol level, dupilumab can be used. Now coming to much more complex algorithm of selecting biological, which is quite complex, but yes, you all can take it from any JM. From there only I've just taken it. So important thing in this algorithm, what I would say, don't always consider all difficult asthma patients as severe asthmatic. Address the other indications, other modifiable factors which should be seen that always confirm your diagnosis, improve your adherence to inhaled corticosteroids, correct inhaler technique should be taught to the patient before considering them severe asthmatic, and look at the other coexisting conditions such as obstructive sleep apnea or heart failure, which is along with the disease or asthma. So now to make things simpler, and the simplistic approach which I believe is much easy to understand and do is that always when a severe asthmatic comes to you, you have assessed and you've said yes, he's a severe asthmatic, assess the biomarkers. Do a pheno test, do a blood eosinophil count, do a sputum or bar eosinophil counts, do a serum Ig levels. And yes, if the pheno level is at a higher level, eosinophil count is at a higher level, or Ig level is in the range of treatment, then we should look at the dominant biomarker, that which biomarker is dominant. So yes, if the eosinophil biomarker is dominant, then the treatment of choice is anti-IL-5. If pheno is dominant, then again anti-IL-5 can be used, but anti-IL-5 and anti-IL-alpha is the one which should be considered. If it is allergic dominant, then omalizumab or anti-Ig is to be used. If eosinophil or pheno or both are low, then anti-Ig is to be used. But in certain conditions, what we usually find that all the biomarkers are raised. In that condition, we should evaluate for the comorbidities and other conditions which are there. But if the patient is OCS dependent, then again anti-IL-5 and anti-IL-5 alpha should be considered. If patient has atopic dermatitis, then anti-IL-5 alpha should be used. If patient has nasopharyngitis or chronic sinusitis, mepolizumab should be considered. Patient has chronic urticaria along with it, then anti-IgE can be used, but supporting the evidence for dupilumab is also there. In reproductive age groups, when the patient is pregnant at times, what to do in such situations? So safety data only for omalizumab at the moment we do have, and there is not much of reassuring data from other biologicals because they are quite new and have not been used in pregnancy much. So the third and most important thing I would say is the patient factors. Always discuss with the patient that when you're starting a biological, because you have to look for who is going to pay for it. Is insurance going to help or not? Is there any family support or not? What is the comfort level of the patient? Because some biologicals can be injected at home, some have to be needed to come to the hospital or the clinic of the patient. Caretaker responsibility, who's going to get the patient here? What is the frequency of travel? Is he able to come every 2 weekly to my office, or would he be comfortable coming in once in 2 months? So accordingly, you have to decide. Cyclosurgical history and all these things are very important. So a shared decision should be made. Now coming to the criteria, that when would you consider a good response from a biological? So say if in India we have only anti-Ig and anti-IL-5, so if you're giving anti-Ig, so before starting is make sure that patient is sensitization to spin prick paste or specific Ig for alloallergens. Total serum Ig level should be in the range of the treatment for omalizumab, and patient should have history of exacerbation in last years. So if eosinophil count is more than 260, pheno is on a higher side, allergy-driven symptoms and childhood onset asthma, results are going to be good and you're going to get a good response. For anti-IL-5 or mepolizumab or benrolizumab you're starting, make sure that the patient is eligible for it. He has got high eosinophil count, there should more than 300, exacerbation rates in last year are there or not. And a good response will be seen if AAC level is more than 500, more exacerbations in previous year, more than one, adult onset asthma symptoms are there, and nasal polyposis along with their chronic sinusitis, then the response with mepoli and benrolizumab is going to be better. So now coming to monitoring response of biological. So it is not a magic trick that you just inject and the response will be there. You should always wait for at least 4 months to say that yes, the response is not there. And clinical goals can again vary from one person to another. For a patient, the clinical goal might be just to reduce the oral corticosteroids. For the other, the overall asthma symptoms should reduce. So that is very important. And response criteria, what you should do before starting the treatment, which you tell the patient that I would consider a good response with the decrease of exacerbation by almost 50%, decrease in oral corticosteroids by 50%, decrease in symptoms, and improvement in ACQ scores. So that is important. So documentation is very important before starting a biological. And at times the response is not really good. And the reasons for that may be that the background treatment with inhaled corticosteroid might have been stopped by the patient on his own. So it is very important to continue your background treatment along with biologicals for the initial period. Sometimes there is poor management of coexisting conditions such as obesity, which can also lead to symptoms. And it has been also found that over a period of time, neutralizing antibodies also develop and the response vanishes. So now important concept comes that if the response is not there, what to do? We have started a biological. So a new concept of switching of biologicals have come here, that when to switch from one biological to another biological. Say if we were on normalizumab, we'll push towards benrolizumab or mepolizumab. And most of the data is available only from the switching from omalizumab to IL-R5s. So in case of poor response, we will switch. And asthma has got a dynamic nature. So initially a biomarker may be on the higher sides, may anti-Ig levels were higher. But later on, over a period of time, that Ig level must have fallen and eosinophil counts are the ones which are actually leading to symptoms. So it keeps on changing its biomarker. So we might need to switch on. So checking for the biomarkers in between is important. Adverse effects, sometimes the patient might have a anaphylaxis reaction or local site reaction with a biological. He says that, no, I won't use it. Then you need to switch it. Patient preference is important, and new research and novel biologicals are coming and new indications are coming regularly, which might lead to switching of the biologicals. So I would conclude my study with these words that asthma therapy has evolved. It has become much more personalized. Biologicals can reduce exacerbation, reduce steroid dosage and side effects, and improve symptoms and quality of life. But in end, only one word I would say, judicious use of biologicals is very important. Just don't give left and right to everybody. That is the important thing. Thank you very much.
Thank you very much, Dr. Siddharth. Any question? One or two quick questions.
Sir, are they helpful in preventing nasal polyposis, recurrence of nasal polyposis?
Sir, actually, if nasal polyposis is caused due to the allergic conditions, then yes, it would help. But I have not read much of data over it. But in nasal polyposis, yes, if patient who is asthmatic and has nasal polyposis, definitely a good response will be there in the asthma symptoms.
Sir,
Can I answer that? I have been using omalizumab, not a very long experience, but I found it very useful, especially in recurrent polyposis, and where patient had history of repeated surgeries. In spite of all the treatment, the polyps come back, and especially where there was a allergic fungal sinusitis was involved, this was very useful.
Medication, what happened? Polyposis reoccurred or not? I just stopped. Because that is important, basically, yeah. Perfect. It is recommended also to use. There is no problem. But I just wanted your experience. After stopping, what happens? You tell me later on. Okay.
Actually, but what I feel, sir, because once it's stopped, I think the response will gradually wean off. Because it's the same in asthma. You have to continue it for an indefinite period of time at the moment. Those trials are going on. But yes, if you stop it completely, the symptoms would come back sooner or later. You can switch, ma'am, because once the response stops and you think that yes, the biomarker, which was the initial biomarker, say serum Ig level was raised, but later on that level has fallen down and you find that the symptoms are there and eosinophil counts are on a higher side, you need to switch because it's quite dynamic. If the phenol level has increased, then accordingly you have to switch. Ma'am, I'm not quite sure about that, but few trials are there in which both are being used, but the results I'm not quite yet, I don't have those results at the moment. Actually, ma'am, I've read most of it about the asthma, not about all these things. I wouldn't be the right person to answer it at the moment. Cost of treatment is quite high. For omalizumab, now biosimilars are available in India. That is around 10 to 12,000. For benrolizumab and mepolizumab, you have to shell out quite a good amount of money.
Sir, can a patient be simultaneously on immunotherapy and biologicals?
It can be done.
Okay, so if patient does it,
benefits the immunotherapy also. So there are studies done. So suppose the patient has a very severe symptoms, but because immunotherapy will take its own time. So you add on a biologic also and simultaneously use the immunotherapy. It helps a lot.
I don't have the data, but in the adverse effects, if you look at the whole of the charts, there is nothing that has been reported on that.
Sir, using the biologics, what is the risk for developing tuberculosis or immunotherapy?
Negligible, I think.
Negligible.
They've not reported anything like that.
We did around 120 patients omalizumab, 3 clinical trials. So even 2 patients had a tuberculosis test positive also, but nothing happened. I mean, it's very safe.
Biologics together.
Steroids you can start, definitely steroid has to be continued along with biologics and gradually it has to be tapered down. The baseline treatment has to be continued when you're starting biologics. It is not that you started biologics, you'll just remove the baseline treatment.
Oral steroids can be given.
It can be given over a period of time and gradually we have seen that reduces over a period of time.
Yeah, thank you, Siddharth, for your nice presentation. And now we'll invite the next speaker, Dr. Vijay Bharat. He will be speaking on house dust mite management strategies. And he is a faculty at ICAI and IAP. He has clinical experience with more than 25 years, and he's been, I think, faculty review with IACI, with the American College. He has conducted approximately 100 trials, and he is advisory board of various national and international journals. And he has delivered multiple lectures in national and international conferences. And I think I invite Dr. Farad for the talk.
So till that I will continuing with my second lecture, that is on the drug allergy. Okay. So we are discussing all about in the last 4.5 days about the allergies, how to diagnose, what are the options for immunotherapy, what are the different type of immunotherapy. Then we go for the rhinitis, asthma, and then skin. Now the 2 lecture remaining is the drug and the pediatric allergy. In the next 20 to 15 minutes, I am just go through the drug allergy. So the drug allergy is slightly different from what we learned in the last 2 days. Is the drug allergy are different drug allergy with different group of drugs. Some group have some other manifestation, some group have some other manifestation. And similarly, the diagnostic tool are also different. We need to do the skin prick test, we need to do the intradermal test, sometimes patch test, sometimes in vivo test like specific IgE, then tryptase level, then basophil activation, and challenge. So the test is varies according to the what drug you are testing. So and then the last purpose of the drug allergy is to just to label or dislabel the drug, and to whether we can give or replace these drugs with other. So here we are not going to give allergen immunotherapy. We just label, delabel, can we give this drug or to replace this drug with the other drug. This is the main purpose of this topic. So what's drug allergy? Drug allergy comprises a spectrum of immunologically mediated hypersensitivity reaction varying from mechanism and clinical presentation. Not only affect the quality of life, but also lead to delayed treatment, unnecessary investigation, and eventually mortality. This merit of the symptom diagnosis is often challenging, and experience in identification, diagnosis, management is recommended if it is suspected. Diagnostic again rely upon the history and the examination. In some instance, the other testing like already skin prick test, challenge are required. So some glossy about this drug allergy before we go into the drug allergy. What do you mean by delay hypersensitivity reaction? It is a immunologically mediated reaction that's occur at least 6 hours after the dosing. Majority occurring within 1 or 2 weeks after the initiation is known as delayed hypersensitivity reaction. Then one term is delay intradermal testing. Here, after the intradermal injection, non-irritating drugs on the forearm followed by evaluation per the duration at 24 hours. In skin prick test, in intradermal test, we do the reading at 15 minutes. Here it is doing after 24 hours. Desensitization is a temporary induction of drug tolerance, typically for IgE reaction through administration of multiple gradation dose of drugs for the treatment, what we do in the ATT and that like that. Maintaining exposure to its required continue temporary induction, these are induction of the drug tolerance. Then drug challenge, procedure where drug is administered to determine the tolerance. Sometimes it also called drug provocation or drug dose, test dose. The challenge, drug challenge are performing without prion skin testing. There are two types. Step one, the whole of the treatment is given, administered, and then observation. In the step two, 1/10 of the drug is administered, then look for the reaction. If not, remaining we administer after that. Then there are also some multiple days challenge, these tests are also doing. Adverse drug reaction, it is a defined as any harmful or unintentional reaction to the drug that occur at the dose used for prevention, diagnosis and treatment. What the harmful reaction occurring after our this treatment of these drugs. They are classified into two types, that is predictable A type and non-predictable, unpredictable B type. The type A are the most common type, usually dose dependent, related to non-pharmacological action, this including side effect, overdose, drug interaction. These are the commonly seen in nearly 80% of our. Unpredicted or type B are approximately in 20 to 25% who experience adverse drug reaction. These reactions are generally unrelated to the pharmacological action. The type 1 are overdose due to secondary drug effect, side effect, drug interaction, where the type 2 unpredictable are the drug allergic, immunologically mediated reaction, pseudo drug allergic reaction that same clinical manifestation as drug reaction, but that's like the immunological specificity. Intolerance is undesirable pharmacological effect that occur at low or sometimes subtherapeutic dose, and they are caused by underlying abnormality of the metabolism or drug excretion. Then idiosyncratic reaction is an abnormal or unexpected effect that usually caused by underlying abnormality of metabolism, excretion and bioavailability. This we already discussed day before yesterday, what are the grading of the drug reaction and anaphylaxis. They are maybe immunologically IgE mediated, they may be immunological IgE independent and non-immunological mechanism, that is direct mast cells activation. This we all know from our first year MBBS. These are 4 types, type 1, type 2, type 3 and type 4. Type 1 is IgE mediated. We discussing from last 3-4 days mainly about this, like anaphylaxis, urticaria, angioedema occurring within the minute. While type 2 are IgG or IgA mediated, like anemia, cytopenia, the time is variable. And the type 3 is immune mediated, like serum sickness and vasculitis acquiring within 1 to 3 weeks after the exposure. And type 4 is MCA presentation of drug to T cell with cytokine and inflammatory mediated release, like contact sensitivity, skin rashes. These are the which occur within 2 to 7 days. So what is the mechanism? There are 2 theories to explain how this molecular weight compound drug is able to stimulate the immune response. One is the heptane hypothesis. Here the drugs bind with the macromolecules such as albumin, which is then processed by antigen presenting cell and presented to T cell that recognize the modified SEP protein. The other one is the pharmacological interaction hypothesis, where the drug bind to the surface receptor is the major histocompatibility complex in the T cell receptor and modify its structure so it is recognized by the other cells for adaptive immune response and thereby stimulating immune response. For higher molecular weight, such the monoclonal antibody often contain murine derivative structure which are recognized as foreign by the immune system, resulting in both type 1 and type 2 reactions. Mast cell activation are universally recognized as essential in the anaphylaxis reaction and can be activated through the cross-linkage with Fc epsilon R1 receptor. The other signal for activation are complement 3A and 5A and compound 48 and 80 and many endogenous and natural exogenous ligand. They sometimes direct canine activation is also leads and are activated through the receptors such as MAS-G protein coupled receptor membrane. This diagram shows the primary complement mediated in the FCG reaction of the anaphylaxis. Here direct the canine system is directly involved and here through the receptors. So these are maybe immune or allergic or non-immune. Immune are the immune mediator are commonly occurring within the 1 hour of the exposure, while non-immune are delay type of the reaction. Then they are maybe the drug reaction may have many risk factors, both patient related as well as drug related. Among the patient related, it may be the age of patient, gender, genetics of the patient, severe infection and previous reaction. While drug, they are depend upon the molecular weight of the compounds, the routes of the intravenous is more reaction than the oral, frequency of drug is also the factors. So coming to diagnosis, how we diagnose, history and the physical examination are compatible with the characteristic, the timing of induced reaction. Depending upon the history and examination, diagnostic tests are different tests we requiring. Therefore, allergy is suspected, evaluated by allergologist. Experience in this is recommended. So clinical presentation, skin is most frequently and prominently affected. Most common manifestation, generalized maculopapular rash, characterized by raised, pink or edematous lesion. Hives and angioedema are also common. Most severe form are Stevens-Johnson syndrome and toxic epidermal necrolysis. Stevens-Johnson syndrome begins with maculopapular rash that progress to bulla, mucous membrane ulceration, conjunctivitis, fever, sore throat and fatigue. Where 10 is a rare with a similar to Stevens-Johnson, but it's cause large proportion of the epidermis detached from the layers, leading to extensive exploration and scalded skin appearance. Other than skin, other organ involvement such as renal, hepatic, hematological system, multi-organ reaction may also occur, including anaphylaxis. Drug rashes, eosinophilia, Dress syndrome, and the serum sickness are also seen. So the reaction, different type of skin reaction depend upon the drug and the duration. The common are IgE mediated and the fixed drugs are commonly seen within the hours or days, while some of the drugs seen even after the months, weeks and months. So these are the various, the picture showing various form of drug reaction. Here it is the multiform drug eruption or eczematous. The lesions are like this. In the skin, fixed skin eruption is look like this. Urticaria usually associated with the angioedema swelling like this, swelling in the race of the skin lesion. In the there is the detachment of the skin from the skin surface, and in the Stevens-Johnson syndrome, all the symptoms, sore throat, skin lesion, ulceration, all coming together. So differential diagnosis, IgE mediated, we already discussed from yesterday, anything carcinoid, insect bite, mastocytosis, severe asthma, food allergy, latex allergy, infection. While in non-IgE mediated, that can be acute or graft horse disease, Kawasaki disease, steel disease, and psoriasis. Insect bite and sting, and the viral infection. So diagnosis, various tests, I already say skin prick test, patch test, serum specific IgE, histamine and tapase level, basophil activation and drug challenge. These according to the drug we can go. So drug challenge is considered as the gold standard. Diagnostic of test depend upon the primary and immediate skin testing and drug challenge. Delay skin reaction and patch test even evolve role in diagnosis in certain phenotype. Evidences for all testing modality for delay hypersensitivity limited and have low certainty. In contrast to drug skin testing, direct challenge is considered a reference standard for determining tolerance. Certainly clinical diagnosis is still considered as gold standard. Coming to the skin prick test procedure, SPT and intradermal test useful for IgE mediated in some selected disease, drugs like penicillin, standardized for penicillin, and also useful for local anesthetic, muscle relaxant, and very sensitive for high molecular weight proteins such as insulin and monoclonal antibodies. Positive skin test confirm the presence of antigen specific Ig in support diagnosis. Negative test is high and useful for ruling out the penicillin allergy. Patch test, we already Dr. Mahesh Goyal had shown how to do, what are the drugs to be stopped, how to apply the skin test. Day before yesterday, he already shown all the method of how to do the patch test. The use of intradermal and patch test for drug is less uniformly adopted as there is overall lack of FDA approval for all type of the centered, specialized centered and standardized method. There is a lack of information of prevalent highest non-irritating concentration for most of the drugs. Evidence suggests that delay intradermal test is more sensitive than patch test for certain delay reactions such as MDE and dry syndrome. Coming to the specific IgE, serum specific IgE available limited drugs. It is not available for all the drugs, costly and generally less sensitive. More of these vitro tests are not adequately validated for drug testing. Most clinicians, serum specific IgE for medication are not used for diagnosis of drug allergy. In a recent meta-analysis, it is found that specific IgE has sensitivity of only nearly 20, that is 19%. However, it is highly specific with area under curve of 0.42. Little about the typase level. Measurement of typase level are prove useful in confirming IgE mediated reaction, particularly anaphylaxis and drug reaction. However, negative does not rule out it. It's increased within the 15 minutes to 3 hours, level peak between 1 or 2 hours. So if it is available in routinely every 15 minutes or 13 minutes we do, then it has a high chance to get the age, however it is. Basal typase level in healthy individual is 0 to 11.4. This level of more than 120% from baseline plus 2 nanogram is significantly increased. Most common disorder typase level of more than 20 nanogram is considered as a minor criteria. Sequential measurement, I already told, has a better result than a just one test. Then coming to the basophil activation test, it involves both the immune mediated and non-immune mediated reaction. Some evidences suggest that it is used for evaluating possible allergic to beta-lactamase, NSAID and muscle relaxant factor that can affect beds or time of the blood collection and the test performance, medication, material use and flow cytometry. So here we use the blood and then it's the whole blood and then incubate it, red cell lysis and then flow cytometry is done. This study has shown that it is good for beta-lactamase and more good for neuromusculating blocking agent with a specificity of 80 and sensitivity of more than 96%. Recent studies are coming more with this. Drug challenge diagnostic test considered standard to determine whether the patient may safely take the medication. Other drug provocation test, the term drug recommended it keeping the open drug challenge and simple single blind challenge test. Drug challenge are typically indicated patients who are evaluating are deemed unlikely to be allergic to this drug. These are the common contraindication for drug challenge: severe cutaneous induction, drug-induced neutrophilic dermatositis, drug-induced autoimmune disease, other cutaneous drug reaction, severe drug anaphylaxis, organ-specific drug reaction, drug-induced vasculitis, and angiotensin-converting inhibitor angioedema. These are the some two studies showing the drug challenge stage. In this multicentric study of 356 patients, 118 took the drug, found negative except 9 positive reaction. Out of these 9, only 4 reevaluated and 2 are reacting. Overall result shows that the negative predictive value is 94 for drug challenge. And another pediatric age group for the negative predictive value among the children of in the Turkey found that out of 91 children, they are positive only in 11. Out of those reevaluating, only 2 positive. Again, that highly negative predictive value of 96%. So the drug challenge have high negative predictability, but similar to all other tests, they are not infallible. Therefore, guidelines recommended that patient to be delabeled following negative drug challenge test. Open drug challenge, I already say step 1, full tablet is given and then observe for immediate action, observed at 30 to 60 minutes. 2 step, 1/4 of the tablet, 1/10 of the injection, 30 to 60 minutes. After, if no reaction, remaining of the drugs given, and again after 30 to 60 minutes. Criteria, consider positive if urticaria, angioedema, eczematous, wheezing, hypoxia, hypotension, and anaphylaxis are there. Possible flushing, vomiting, cough, abdominal cramps, pruritus, and fever, and eye soreness. Doubtful tachycardia and subject to lip and tongue swelling. For delay, same, but the reading is done at 1 to 2 hours, and again 30 minutes, and again after 2 hours. The criteria is same. The guideline recommended it that suggests that when the clinically probability of drug allergy is low, patient without contraindication for drug challenge, it is performed with 1 or 2 step drug challenge. Single blind control, give the placebo 30 minutes observe, second placebo 30 minutes observe in immediate reaction, then full dose in after 1 hour. In delay type, placebo 30 minutes in the office and return within 3 to 7 days, again a placebo, same in the, then the full dose in the, keep for 30 minutes in the office and reading after 3 to 7 days. The drug challenge should be considered positive if result is subject to. In the guidelines recommended that it suggests that placebo controlled drug challenge is considered in a patient with history of primary subject to symptoms and or of multiple report of drug allergy with a condition and very low evidence. This is the meta-analysis for penicillin diagnosis for the skin prick test in specific IgE level. And they found that out of 105 study of more than 31,000, skin prick test has a sensitivity of just 37%. However, it is highly specific with nearly 97, with ROC of 0.68. While specific IgE again lesser than that, the sensitivity of 19, but the specificity is same with ROC of 4.2. They concluded that skin test and specific IgE appear to have low sensitivity, high specificity. Current evidence is insufficient for stratifying patient for delabeling. We identify a key requirement need in the future studies. What's the guideline recommended updated? They recommended the proactive effort should be made to delabel the patient with reported allergy to penicillin with strong recommendation and moderate evidences. They recommended again any testing in patient with history inconsistent with, so history is very important, but step 1 amoxicillin challenge may be offered to patients who are anxious or require additional reassurance to accept the removal of penicillin. Again strong recommendation. Suggest penicillin skin testing per patient with history of anaphylaxis or recent reaction suspected of IgE, conditional recommendation. Recommended again routine use of multi-day challenge in the evaluation of penicillin allergy, again strong recommendation. Sulfonides, they says that patient with history of benign cutaneous reaction to sulfonides, step 1 drug challenge be performed when there is need to delabel to that antibiotic. Fluoroquinine and macrolides, step 1, step 2 challenge without preceding skin testing to confirm in patient with history of non-anaphylactic reactions. Conditional recommendation. Aspirin and NSAID, selective COX inhibitor may be used as alternative analgesic in patient with any NSAID hypersensitivity when NSAID is need. Recommendation again aspirin's challenge to confirm the diagnosis in aspirin exacerbated respiratory disease in diagnostic uncertainty in clinical history. However, aspirin desensitization remain as a therapeutic option. Again, strong recommendation. Suggests an oral aspirin challenge to confirm the diagnosis of AERD in case of diagnosis uncertainty. Conditional recommendation. Suggests that challenge procedure may be used for diagnosis of AERD when the diagnosis is uncertain and the desensitization protocol to be used when intended to place a daily therapeutic aspirin. Again, a condition recommendation. Biologic suggests that the patient with known immune reaction or history of reaction inconsistent with monoclonal antibody hypersensitivity may be considered with slow infusion rate, graded dose acceleration in pre-medication without desensitization. So reduce the dose, slow the infusion. Suggests that patient with immediate reaction or history of consistent with anaphylaxis, drug desensitization should be considered when implemented drug is peripheral therapy. What new in this guideline is that sensitization one or two step challenge have low risk for patient. Suggests to use placebo challenge in subject to symptoms with multiple reported drug allergies. Suggests was considered delay intradermal or pastage to identify culprit drug for delay drug reaction when implemented agent is uncertain. Recommended a proactive penicillin allergy delabeling. Suggests use oral aspirin where diagnostic uncertainty. Suggests for non-IgE reaction to monoclonal antibody may be treated with slower infusion, graded dose acceleration in pre-medication without desensitization. This is the algorithm. Already I discussed more of them. For the treatment, key factor of management is stop the suspected drug if it is infusion. Treat the reaction, identify and avoid potential cross-reacting drugs, pre-medication with antihistaminic, steroid and NSAID, slow infusion rate of the contrast and biologicals in another option, record precise detail of the reaction and its treatment, if possibly identify a safe alternative, if necessary consider desensitization but rarely indicated. That's all from my side. Thank you very much.
Dr. Sir.
For this, I am calling for the chairperson is Dr. Nitin Goel and Dr. Siddharth Raj Yadav.
So continuing with the session, we have with us Dr. Vijay Varad. Sir is allergist and clinical immunologist since 25 years and faculty in ICAI IAP Allergy Chapter, World Allergy Organization. And he has to his credit about 100 clinical trials on various aspects of allergy and asthma. To cut short, sir is going to take topic on house dust mite management. Over to you, sir.
So thanks to Dr. Rajkumar sir and for the inviting me for a 49th workshop and all the organizing team of VP Chest. I think last 3 days you must have heard about dust mites a lot, and they are a very important factor in allergy management. Even few years back when I had been the same institute for one of the ICACon, there Dr. A.B. Singh sir had presented papers on dust mites and all. So I saw Dr. S.B. Zogdan, and when, he was my teacher in 11th, 12th and he was under my father as a botanist, and in 4th standard he had shown me the dust mites. Then I recollected back. So that way dust mites are so much, and he has presented 37 papers internationally also on dust mites. He has a lot of studies in India he did on dust mites. So if you see the Indian College of Allergy, Asthma, Immunology also, the focus medical history first, then clinically think about what should be the causative factors and all, identify the allergens with the standardized skin allergy test. Whatever the blood allergy test the people are claiming, like 4 years back I also held the component-is-all diagnosis, they claimed around 90-95% accuracy. Still it is not that much. I mean, for the environmental allergens it is not needed. Environmental allergens, still the gold standard is the skin prick test. And why I choose a pediatric? Because if you manage the pediatric allergies, we can stop the progress of the disease leading to the severe allergies adulthood and the complications of the allergic march. So like this child had a 14-year-old male we had with a history of asthma, moderate to severe allergic rhinitis, and with all the standard treatment he was getting, but he used to have a daytime sedation regularly, so his quality of life was poor basically. So we did a skin prick test and it showed this. So Ferini terunoceus as compared to the histamine was positive, alternaria was 7/7. So last 3 days you are attending. So what do you feel like? What should be we focus on this case? Where we should have a focus? Yes, and most of the symptoms in this case is indoor. See, alternaria is the outdoor mold basically. So the focus should be on the dust mites. So clinical correlation is very important. So the sensitivity can be multiple sensitizations, but we have to clinically correlate. Then this was a child which had a very severe hypoxia after eating a peanut butter. The parents for 2 years, they were in USA and they had shifted last 3 years in Pune, Karadi. They taught us a peanut anaphylaxis, but it was because of the dust mites contaminated significantly into that peanut butter. So this case I discussed with the allergologist in India also, as well as I am on the environmental committee of American College of Allergy. So there's few cases are there, even this dust mite contaminated things can cause a significant anaphylaxis. So this child had a seizures post hypoxia, and then he was referred to me for a repeated cough cold which was not going away. So they were not ready to accept. Then we did a CRD also, we did a skin prick test. Then we gave then some examples internationally what has happened. This was another case referred from a corporate hospital. The child was referred for me for 3 admissions into the ICU because of the severe bronchitis. And considering after visited 8 to 10 dermatologists, the parents were told that the eczema is going to be there. He used to each throughout the night, the blood used to be there. They could not take the child anywhere into the society because it was very cumbersome for them. We did a testing, CRD as well as the skin prick. It was a significant dust mite. IG was very high. We started managing along with the milk also. The sensitivity to the milk was also significant. And within 9 months, he has such a good clearance. Last 4.5 to 5 years, never required any admissions. Hardly some seasonal cold cough is there. So the dust mites are very important, and even some of the cases of eczema also, and in urticarias also practically I have found very useful, where there is a significant family history and the patient has a hidden signs of allergy. Like I think you must be knowing now till now, what are the hidden signs like. So this was again another case. You can see like this is a very disturbing. All over the world, even in Indian scenario, because my spouse, Dr. Ushalis, is in ocular allergy, so we get a lot of referrals, and it is the most underestimated, underdiagnosed and overlooked allergy amongst the allergic diseases, and such a significant. So this child had also, whenever he used to go in the bed, maybe in the mid afternoon or in the night, he used to have a significant in the early morning also. So after desensitization, he is much better. So these, you cannot see these allergens. So this recently in Denmark I recorded the video like how, so they are in crores. So daily we said around 1.5 gram of skin, and 1 gram of skin, more than 10 lakh dust mites can survive. So they are everywhere in the cushions, like wherever we are sitting now. If you see that, we can't sit over there, we will not sit on the cushions. So in the car, everywhere there. So while managing the avoidance strategies amongst all the allergens, the dust mite is always given a significant priority, and Dr. Rathi had already spoke on that. So these are the common allergens we know, and Indian scenario, like these are the common ones. Amongst the avoidance measures, once we identify clinically, then we document with the tests, we can definitely reduce the burden of the anti-allergics, steroids also. 2020 when I took a lecture for IIP, and the use, abuse and overuse of anti-allergics and steroids in India, I was shocked. So many steroids are given, like Dr. Siddharth said. Practically in pediatric age group also. Just few days back only I had a 14-year-old child. Last 2 months he has been given 4 times steroids, 5 days doses. Significant one. Like once it was a betnesol, one was a Degdac, one time he was given a Visulon. So many overuse of steroids are happening. So by some of the precautions, as Dr. Rathi told about all these things, so I will not go into the details, but the important is stop dusting. After completing treatment from me for 4-5 years also, still the mother or the grandmother will never stop brooming. So they are just, all these allergens are into the air again, and they are going onto the bed, sofas. So it should be always, the vacuum cleaning should be done rather than the dusting. So even the World Health Organization since 1998 has said that avoidance is the only primary one. And then whenever required, desensitization. These are the only things, they can be a disease modifying for the patient. And as I mentioned, I showed the picture like allergic march prevention should be our aim. So even the GINA also has said that the sublingual immunotherapy in an early stage, even in the stage 1 also, if it is a significant findings are there, clinical correlation, And specifically the permission is still now for the dust mites. So dust mite are very important. So there are two types we all know, like injectable and sublingual. Sublingual are in a tablet and drops form. And as Rajkumar sir said, I will focus on the more onto the sublingual because till now you have been all trained in subcutaneous. But now I was doing a acaroid trial for the subcutaneous. In between it is stopped because of the shortage of the acaroid subcutaneous shots. So there are some studies done like how it is efficacious. This purified form of immunotherapies will be further in subcutaneous also in Indian scenario. Still, whatever the trials have been done in worldwide, the subcutaneous immunotherapy is less costly than the sublingual. So again, this must be some of the slides may be the repetitions since 2 days. Even the IACI guidelines, they have mentioned about the house dust mite desensitization and to stop the atopic march. So there is a very good evidence for the dust mite and pollen desensitization. In our country, the insects are also there and different types of molds and all. So if you see the evolution of the immunotherapy now, we have come to the allergoid acaroid form of immunotherapies as well as slit tablets. Recently, last 6 months, they are available in Indian scenario. Okay. So if you treat properly the purest form of immunotherapy, the less reactions will be in the subcutaneous. Why in India 90 to 95% of the practitioners have shifted to sublingual because of the scare that the subcutaneous have a reactions. So the institutes, it is practiced very well, but in a private practice, most of the private practitioners are not comfortable because of the reactions. And the colleagues, like suppose in between when the Merck had been with the skit, I used in many patients because that was more standardized. And so some of the physicians were ready to use that because each and every patient can't come to the same center repeatedly. So, but now again, it becomes difficult because the physicians and the pediatricians are not ready to give the patients subcutaneous one. It can be given by the patients also outside. The people are taking themselves also. During the COVID era, I think omalizumab, my 40 to 50 patients were taking at home only. So that way, the skit also can be done, but in Indian scenario, it is more difficult. So if you see the differentiation, even 2013, the World Allergy Organization meet was in Hyderabad, and they found that long-term the immunotherapy, the benefits of IgG1, IgG4 antibodies are comparable to both. I mean, slit and skit. Skit is more studied worldwide and it is used, but slit also now it has picked up very well in Europe and Indian country. Even recently, 2 doctors were from Bangladesh, so they have also started slit therapy because of the tablet form which is available in India now. Slit, the recent tablet, it has to be given daily. Previously, the drops were there like a twice a week and all people were using, but now this tablet form has to be given daily. So this is the now which has been introduced in India, the Sensimune by Dr. Reddy's. These are 12 SQ HDM slit tablets. 6 SQ slit tablets are available in Japan at present for children between 6 to 12 years. But these 12 SQ tablets are above 12 years. So you can see like how these are placed just below the sublingual. The dendritic cells into the sublingual mucosa, they absorb the extract from there and they form the IgG1, IgG4 antibodies. So that's why the systemic reactions like subcutaneous immunotherapy, SCIT, are not much here. The localized reactions are there. So these are the solubilized allergen molecules that interact with the antigen presenting cells of the oral mucosa. So they are primarily polypeptides and proteins. And through the oral mucosa by the dendritic cells, which is not absorbed, being hydrolyzed to the amino acids and small polypeptides in the lumen of the GI tract. So these are the patients which can be eligible for the tablet form HDM. So the asthma not well controlled on ICS therapy like GINA 3 and 4. But in one slide I showed like GINA is recommending even the step 1 also, where there is a significant history, family history, and if the risk of allergic march is there. So nocturnal awakening due to asthma, increased daytime asthma symptoms, increased usage of asthma reliever medications, activity limitations due to asthma like missing work, school, sport, leisure, then symptoms triggered by the specifically early morning or late night or exposure to the dust. Like I remember there was a 6-year-old child, they had been from Belgium in Pune, and the child was given some vaccination and he had a significant reaction. So they were blaming the vaccine. When we asked the detailed history, that house was closed, the old sofa, the child was playing over there, and the child had a milk sensitivity and some lentil, so they both were given. After the test, we documented that, and then he had a trigger of urticaria and all. So these dust mites can be triggered by such type of old clothes or some sofas and all. Sleep disturbance, itchy watery eyes, nasal congestion, sneezing, itchy sore throat. Ocular, these occur all around and can get worse in winter months than staying indoors. Occur during the house dust mite exposure when cleaning, fluctuate with change in the environment when traveling. And the diagnosis confirmation has to be there with the standardized skin prick test. Specific IG still very few patients require it. Most of the time the standardized skin allergy tests are helpful. Some patients, like one patient only, the skin prick was negative, but when we did a CRD, it was showing a significant blomia. A 23-year-old patient was there and it was clinically correlating. So sometimes we have to do both the tests. Now the good part is that previously the multiplex whole assay was available. So the patient has to spend 22,000. Now there is a single plex assay available. So even the individualized dust mite, if you want to have a DERP1, DERP1, DERP2 or 23 or blomia, we can do in a 3,500 rupees that way. So some of the patients we can do both the tests. So the most important is that if the patient is asthma, the FEV1 should be more than 70%. If it is less than that, control it with steroids, nebulization or biologics. Again improve the FEV1 and then start sublingual immunotherapy. Contraindications, hypersensitivity to any of the excipients. Till now very few patients have that. Around 82 patients I have given the tablet now. Till now, and nobody has a problem. Only one child, 16-year-old, we had explained them properly, but he took a empty stomach in the morning while going to the class. So he had some giddiness and also they stopped it. So otherwise, very few patients have some throat problem. Some patient had a localized irritation and some ulcers were there. One patient had some lipedema. It lasted for a few days. We gave a bilastine before giving the tablet. 2 hours before, so it also went away. So in patients with asthma experiencing acute respiratory tract infections, stop it for a few days, then again reintroduce after some time. Patients with activity of poorly controlled autoimmune diseases, immune defects, immunodeficiencies, immunosuppression or malignant neoplastic diseases with current disease relevance. So this has to be also inquired properly, because I remember one of the ophthalmologist wife, some other place at chest physician had given us sublingual drops. She had already some autoimmune diseases and all. She started developing a ILD. So sometimes you have to be you have to ask details, because if there are significant such type of contraindicated diseases, don't start the immunotherapy. Patients with the acute severe oral inflammation or oral wounds. So there are robust evidence for the sublingual immunotherapy. Like 5 days we were in Denmark and we saw a lot of many years they are using a tablet form immunotherapy. And more than 8,700 patients with asthma and rhinitis, and there are different programs where they have used this, and it has been approved in 25 countries. And there are studies done, so 95% treatment related adverse effect assessed as mild and moderate to intensity. Most common were the throat irritation, oral pruritus, ear pruritus or swollen tongue in some patients. And serious adverse events have been reported around 1.3% amongst the tablet form, and again 1.8% among the placebo recipients. So I think it is negligible, and no deaths or anaphylactic shock were reported. Epinephrine use reported in 0.4% subjects who received that, compared to 0.2% who received placebo. So hardly it's like 0.2% patient had a suspected anaphylaxis and given that. They had these are the studies by ALK Pharma basically, because in India still the studies have not been happened with the Sensimune. The same formula is there, only the name is sensibly different. In USA, there is a different name. The ALK from Denmark only is providing everywhere. So they have also found that in thousands of patients they have used it, and the adverse reactions, as we just now discussed, hardly anyone. I mean, and the risk of developing eosinophilic esophagitis has been identified from post-marketing experience. The occurrence is rare. Events of eosinophilic esophagitis are expected to be non-serious and reversible after having discontinued treatment with the HDM slit tablet. Some of the patients, they complain significant stomach ache, gastrointestinal disturbances, my few patients. So we discuss amongst the colleagues which are using that. So then, because the disintegration happens within 15 seconds and maximum 4 to 5 minutes it has to be kept. So what we did is that keep it there and then rinse the mouth and spit it out, because it will not be swallowed and it will not cause those gastrointestinal disturbances or this thing. These are the approved indications, like adult patients between 18 to 65 years, clinical and as well as the positive test for the house dust mite sensitization, and persistent or moderate severe house dust mite allergic rhinitis despite use of symptom relieving medications. House dust mite allergic asthma not well controlled by the inhaled corticosteroids or high dose of ICS therapies associated with mild to severe house dust mite allergic rhinitis, and the asthma status should be carefully evaluated before the initiation of treatment. As I mentioned, more than 70% FEV1 has to be there. And even there are some studies, they have mentioned that the sensitivity, like as compared to the histamine, the positivity should be more. But how much is the more sensitivity means the patient will have more effects. It is not that way. It is efficacious for everyone. And it is indicated in adolescents from 12 to 17 years with the proper clinical history and skin prick test positivity. In Japan, they are using from 6 to 12 years also the 6-SQ tablet. So this is another merit trial where they have done around more than 992 patients, 12-SQ and 6-SQ HDM along with the placebo 338, and the periods like 15 days, then efficacy assessment was analyzed on 2 months and 10 months. So there were males and mean duration of history was 9.9 years, mean one, and allergic HDM sensitivity was around 46% cases. So they found like significant sustained reduction in symptoms after 8 to 14 weeks of treatment, and the symptoms were reduced. So you can see like here the reduction in blocked nose, sneezing, itching, and symptom relief has been in 30% of the cases. And they found a similar and consistent efficacy in between 12 to 17 years and adults also with allergic rhinitis. So total the symptom score had reduction into that, like around 22 to 25%. And as we discussed about that, very mild, these local symptoms were there, like 10% had a mouth edema, oral pruritus in 20%, and throat irritation in 12%. So in asthmatic patients, again, to improve the asthma control assessed by reduced risk of asthma exacerbations, these are the studies basically: moderate to severe HDM allergic asthma, partly controlled asthma, mild to severe HDM allergic rhinitis. And the primary endpoint to time to first moderate or severe asthma exacerbation, and the hazards, anything, they analyze that. So again here also more than 834 patients, and both like 6 to 12 years, the 6-SQ, and above that 12-SQ was used. And they maintained the daily diary in these patients for the PEF and any use of SABAs. And you can see like the inhaled corticosteroid 50% reduction, and after the end of the trial, like they have mentioned ICS to see the efficacy, like how much withdrawal of ICS will be there. So adults more than 18 years, at least 1 year history of persistent asthma was analyzed, and the SPT positivity and specific IG for the Teronesis and Ferini, and documented reversible airway obstruction FEV1 should be more than 70%, asthma control level corresponding to partly control at the randomization. and use of ICS in accordance with the GINA guidelines like step 2 to 4. And so the patients which were on a high ICS and they were not controlled, those were enrolled into that. So based on the largest development program, efficacy has been demonstrated over there with significant improvements in rhinitis symptoms and decreased requirement for rhinitis symptom relieving medication, 25% reduction in daily symptom score, 29 around 30% in daily medication score, a well tolerated safety profile in both rhinitis patient with or without allergic asthma. The tablet is suitable for home administration. No updosing required because whatever the sublingual drops are given, they are giving in updosing also in Indian scenario. So the full dose they have given under the medical supervision. Among adults with HDM allergy related asthma, not well controlled by the ICS, the addition of the tablet to maintain medications, improved time to first moderate or severe asthma exacerbation during the ICS reduction. Treatment related adverse events were common in both active doses. Further studies are needed to assess the long-term efficacy and safety. The fast dissolving tablet, like as I mentioned, within 15 seconds it gets dissolved at the sublingual. So summarizing, the dust mites are the most commonest allergen. Even in seasonal allergies triggered like exacerbated, the primary sensitivity in many patients practically we have found a dust mites. Perennial allergy, mostly dust mite is more predominant. After the details of history, we have to analyze that as we discussed it in details. Then always standardized skin test. Very few patients the CRD can be done, and the precautions and desensitization helps to reduce the symptoms, stop the progress of the disease, to stop the oral steroids as well as to improve the quality of life of the patient. And even many of these patients will have a allergic march also. So to help that way in a long-term basis. Thank you. Thanks a lot.
Thank you, sir, for a brilliant lecture on house dust mite. Any quick questions from the audience? Yes, please.
As per your experience, which should be preferred?
See, as I said, hardly I have used in 78 patients tablet, but 3 to 4 patients, it was a remarkable results. One of the pediatrician from near Sirdi, already we had put the patient on sublingual drops. He had around 30 to 40% efficacy. Then the tablet came, so we shifted to the tablet, and he had a very good recovery now. He has a very good recovery. So there are 2-3 patients like there we found a very good results. The relief is much better as compared to the drops, because the sublingual drops still the standardization is not in India. So now whatever like customization we are doing according to our own experience. Okay. But the tablet is a standardization one. So the trials have been done. In Indian scenario, we don't have a sublingual drops trials. There are no clinical trials as such.
Sir, as compared to SCIT is concerned, we now know that if there is a gap of a month or 2 months or 3 months, then how to proceed, as sir has very well explained us. As regard to this
See,
slit,
there are
how to,
no,
if there is a gap.
There are no clinical trials as much, but the same exploration is used over here also, like 3 months gap, suppose. Then again you can do it. Otherwise you can have to start from the scratch again.
And same, how long? 3 to 5 years, just like
minimum 3 to 5 years.
Okay. Thank you.
Officially they are saying 3 to 4 years, but it is that. See, basically it is still customized. So even the sublingual immunotherapy drops we are using about 2 years also, like that atopic dermatitis with severe bronchitis children. We had started, the child was around 2.5 to 3 years, still we started on that. So depending on the sensitivity of the patient, the severity, we have to assess it. So 1:1000 to 1:500 to 250 to 100 to 150, that way concentration is there. So as you go on practicing, so initially you can start with the more diluted, not much concentration, and then you can, with your experience, you will learn that, like which patient to start 1:500 early, 1:250. So accordingly we can.
And what should be the dosing pattern, means weekly or?
Generally at present in India, most of the doctors are prescribing twice a week. Ideally it should be daily.
Okay.
but the patient don't, and most of the patients are polysensitized, so we have to go pollens also, dust mites, so then it becomes more.
So which one do you prefer, means drops or tablets? Means
No, as I said, see, when the tablet are there, definitely I will go for tablets only. Na?
okay.
It's the most standardized. The cost is more. Problem is that it is around per month 9,000 is the cost. Drops are around 1,200 to 1,400 per month. That way. Tablet at present it is not, I mean, recommended by the whatever the DCGI guidelines below 12 years.
So then below 12,
One of the doctor I have started 8 years old, but he has a significant, the family history is there. He understands, he knows me since many years. So with my experience, I have started that by taking a consent.
So most
Like-
of our patients are 8-9 years old with allergic rhinitis. So a slit drops is a better way than to start. We should start with slit drops then.
Above 8 years, the skit can be given, not below 8 years. But as I mentioned, this allergoid, we are doing a trial above 5 years, skit. So once it is completed, then we can give a skit also above 5 years. But the drops can be given.
Sir, from where to procure this? Sir, from where to procure this antigen kit? Like which brand is the best? Like one
So,
is Alcure is there here. So some other brands are also available in the market, or
See,
which is the good one?
personally, at present, I am using Allcure only, personally. So other things I can't say. I mean,
Hi, sir. Thank you for the brilliant lecture, sir. I just wanted to ask, sir, you said that there is no up titration in the HDM tablets as there is in SLIT. So what happens if we miss the dose? Because the problem was you would restart in SLIT or in SKIT, but here if the dose remains same all throughout, what if the patient is missing the dose? What changes is that?
that we discuss a lot in Denmark also. But still they don't have a answer for that. They said you have to just
Restart it.
and it works that way.
Okay, okay.
They have found ki like it works, like whatever.
Okay, sir.
No,
Thank you.
even you restart also, you have to start the same dose.
So
So,
it
the
works.
patient is more comfortable. Even
But
if he has
they've-
missed, he could restart
yeah, but
it.
it is working. I mean, there is no as such scientific answer for that.
Okay, sir.
Yes.
Thank you.
Okay, okay. Yeah.
What has been your experience to correlate within the input and CRD result?
Sir, as I mentioned in the talk, whatever the CRD they promise, I took also machine very enthusiastically. But ultimately I found that it is useful only for the food anaphylaxis. The environmental allergens, it's not much useful. Environmental allergens, actually the still standardized skin prick test is the best one. Our allergens are much better. I mean, we are using since many years. They are very good. Clinically correlate also very well.
No,
Maximum I have used for 4 to 5 years. Sublingual.
So for skits, there is a build-up phase. For skit, there is build-up phase, like you start from lower concentration to higher concentration. Sir said for slit, there is no build-up phase. So should we start with lower concentration in slit also and move to higher concentration, or?
They did a lot of studies on these tablets. So they found that it is not useful that way. So after all the trials, they have mentioned that it should be started with a high dose only.
No,
There
with
should
the
not be a
drops, with the drops.
Drops we can do it. Drops you can do it, but you have to be very careful because sometimes if it is a non-standardized one, it can introduce the allergy also. I had a child, 13-year-old, and one of the doctor's child, and these some companies are there. They are going the house and they are doing the tests and giving. So it was wrongly given the different type of formulation, and the child started severe eczemas. So it should be under a very proper expert advice only, rather than. So once you do start practicing, then you will learn all this. Like how
What
we
should
started
be the ideal
inhalers.
concentration with
So
which
as I
we
mentioned,
should
it has to
start?
be customized. It is no ideal concentration. I mean, it has to be customized.
Sir, can you please again tell us the proper technique of taking these tablets and drops?
See, tablet are there, na? Just you put it below the tongue, keep it there, tablet within 15 seconds it disintegrates. You can keep it for 2 to 5 minutes. Then spit it out also, it's okay. Drops, it has been found that it should be kept at least more than 5 to 10 minutes because it takes some time rather than the tablet. But 2 to 5 minutes is okay practically.
And then rinse of the mouth as
The drops can be swallowed. I mean, I never found any problem. Very few patients had a stomach ache and some gastritis and all, but otherwise nothing. Tablet, it is high dose. So there are studies like they have found.
Sir, they are saying ki these are off-label drugs. This Alcure person is saying ki this is off-label. What is the meaning of off-label?
See, basically, it is not approved by the FDA, na?
Okay, sir.
DCGI.
So are there any medico-legal using it in?
Yeah. Actually, Alcure, they are not supplying as a sublingual.
No, they are supplying, sir. I asked him.
No, but that basically, with your experience, they will give you with your own risk. So I am taking a risk, na? So I am taking since many years. Okay. So it is that way, basically.
Okay, I will pitch in. So there are many questions, doctor, because you are using basically sublingual immunotherapy, and there are many questions, they might not be coming out. So you already told that sublingual immunotherapy, especially drop, you are taking on your risk and doing everything. That's right. Other things has been, I think, explained. Another question I wanted to ask, because you have been using for last 10, 15, 20 years sublingual oral, but as per the literature, just like Sensiumune, and all the oral immunotherapy, let it be sublingual, let it be tablet, there is no build-up phase. So why there is a need of, I inquired both of companies, I specifically went them ki aap kaise dete hain. So just like skit only, they are making slit also. Means they are starting with the lower dilution and coming up with the high dilution. I feel standardization, FDA, drug controller approving and all those things are separate. You have already explained that. So what is the need of there is a build-up phase in this? Because as per the literature, they should start directly with the maintenance dose.
Yes, sir.
That's right?
Yes, sir. Absolutely right. But the practice is going on, that's why it is continued.
Yeah,
That's the problem.
no, I asked them also. वो तो पुराने जमाने से चला रहा है तो हम भी चला रहे हैं. That's okay. So I think he has clearly told about that. Both the therapies are okay. Correct me. Skit and the slit. Skit has more of the side effect. Slit has less of the side effects. Efficacy wise, some data are there that skit has a more say. Clear cut data is there. But safety wise, the slit is much, much better. Skit, we have lot of experience for so many years. Less experience with the slit. Drops and tablets, both are good. But tablets has been passed by the Drug Controller Authority of India, which has recently 2 months back, it has come here in India. Drops, because I want everything, when you go from here, you should be clear. Whatever you are using, that's a different story. But you should not say the Patel has told like this. Patel says like this, that the drops are basically what is unlabeled, labeled. Whenever any company is telling unlabeled, you should ask them only, what do you mean by that? That is important. Rather than doctor asking, putting the question to the doctor. Another thing, so whatever the drops they are giving, I feel there should not be any build-up phase as per the literature. Directly maintenance as just like the tablets, one. Second, the companies are giving to you officially, unofficially what they are doing, I don't know. Officially they are giving you the concentrated part and asking you to dilute it and give it to you. But for you they are doing, in the back end, for you, they are doing everything and giving to you so that it becomes easier to that. So all the legal complication occurs, it will be on the doctor as a dispensing practitioner. Am I right?
Yes, sir. Okay. Absolutely.
So, yeah, any question you can ask him.
Hello. I have a patient back in Kolkata. He has SPT positive, strongly positive for both HDM as well as one Aspergillus fungi. Okay. Now he is unwilling to take injections. Now after coming here, I have learned about that slit is available only for HDMs. Now my question is, can slit for HDM and skit for this fungi can be applied simultaneously on this patient or not?
Sure. See, first thing is that for the aspergillus and all, generally first hand we don't desensitize.
Okay.
For funguses, we don't desensitize till it is absolutely necessary, and after doing all the things. And in USA they are doing routinely. I mean, I have a lot of USA patients, even the skit also for fungi they are using. But in Indian scenario we don't desensitize. First thing is that. But suppose somebody requires like one tablet and one skit, it can be given. Like pollen, suppose you want to give a skit and you want to give a HDM slit, we can give it, no problem.
Okay. Are there some studies on this?
No, there are no. Because nowhere it is done. Suppose the patient is put on skit, then skit only is given for all the things. If it is slit, then slit only. There are no studies.
Thank you.
Yes. Thank you.
Sir, just wanted to ask, in the 78 patients...
Yes, please, sir.
One study was shown by Mahesh. One of the study was shown by the Mahesh, where they have used basically slit and the skit. That not simultaneously. Initially they have used the slit, and then after that they have the skit.
Yeah, actually, when the Merck had introduced the skit, many of my patients also I shifted to skit, dust mites actually, because it was not standardized one. Affordable patients. It was very costly, so that's why. So that can be, but simultaneously I also never used it. Both, I mean.
So just wanted to ask, in the 78 patients you did the sublingual tablet, was it given daily for them?
Yeah, daily only. It has to be daily. Yes.
And drops
actually,
also ideally are daily,
now
but we give
some of the patients who are doing Indian Jugaad, it's an individual, like alternate day also we are using it. Some patients which are not affording. So that's a different, but it has to be given daily.
Sir, ideally even the oral drops are to be given daily?
Ideally, it should
But
be given.
because usually the dosage schedule that is given to us is either alternate day or then once a week as maintenance.
So as I said, our patients and our so many things are there. Like ideally we can't give antibiotics, but we are using in every viral infection. So the same way in Indian scenario, we have to manage some way, practice, it's different.
So but daily drops can also, if it is allowed and the patient is affording, they can take
ideally
it
it
daily
should
for
be
5
given.
years.
Ideally it should be given, yes.
Also, sir, as Dr. Rajkumar mentioned that if they supply us the concentrated antigen for HDM and we have to dilute it, how is that done?
So as I said, we should not discuss on this trias. We can discuss further.
That's why they are leaving to the one. We are also clever. While ordering them, although you write that sublingual immunotherapy, they will never supply as a sublingual or ELIS, as they write in ISKIT. But what they want is your testing dose, that is 1 in 10 concentration, highly concentrated, this is what they have. It may be 1 in 50 or 1 in 100 at the most, depending on individualized patient's treatment. They supply you as an allergen by 1 in 10 concentration or whatever concentration is available you have asked for. So that's why they will never write something that is not approved by the Drug Controller Government of India. They are still waiting for some trials to do it, and then they will come out some recommendations.
Yeah. So no, Dr. Rajkumar has never told you to do like this.
That is true. Because he himself has not started here.
I told you people, they are doing it undercover to you basically. They are doing it and you are doing it. I will never record it. I will never advocate anyone, any of the doctors to do dispensing practice in the vaccines. Tablets okay, vaccines no. Because reason being, you do not know how to mix and dilute. How many people know weight by volume diluting the vaccines? Anybody? Tell me. So should not take a perception from Patel Chase Institute. Patel Chase says that drops has not been ethically approved by the drug controller of India. What I am saying, because many times question comes on how the people are using. So we are just trying to understand how they are using. So one of the method could be this, in that way the people are using, and Dr. Virat has already told you that he is also doing it in this way, where dispensing practice has been allowed to the doctors. In that respect they are doing it. So from the platform, very clear, drops are not passed by the drug controller of India. I have discussed with all the manufacturers, and if you go for the drug and the tablets, oral immunotherapy, that's why that is the beauty of the oral immunotherapy, where the builder phase is not there. So directly you start, when we teach, basically we teach, what the difference, one difference is this, there is no build-up phase basically for the oral immunotherapy. So that's clear? डॉक्टर रंगे बता ऑफ लेवल का मतलब क्या होता है? डॉक्टरों को आप बोले थे कि ऑफ लेवल होता है. ऑफ लेवल, व्हाट इज द मीनिंग ऑफ द ऑफ लेवल? जस्ट अ डिस्कशन, नथिंग एल्स. Just off label.
Off label actually means it's not recognized by the FDA. That is considered off label because.
So off label, FDA here means drug controller.
CDSCO.
Drug. So off-label means this is not recognized by the drug controller. Am I right?
Yeah, but I would like to add one more thing. Is drops are given all over the world. They are given in US. They are given in UK. The NHS also gives drops.
Yeah.
So it's not that they don't give drops.
No.
There also it is off-label. No, nowhere in the world the drops are approved.
So let us stop this discussion here only. I have a right to stop everything. So clearly, let us not go into the discussion. The people are using it. It's fine. I'm not telling this is right, this is wrong. Drug tablets and the drops are very good basically. Rather, I will show the slide. I am going to show you the slide where I will tell the the drops are better than the tablet. So they are good. So we are just talking about the process basically, not the vaccine or the drug. So okay, so we continue that, na?
So for the next talk, we have Professor Rajkumar, who will be taking his lecture on setting up an allergy clinic.
इसमें दिखाओगे जरा. So before Dr. A.V. Singh, you are going? Okay, before I move to the setting of the clinic, I will just spend 5 minutes which I told you. Just 5 minutes. Yeah. So in the basically you should attend the conferences also. Like Indian College of Allergy, Asthma and Immunology also organize the conferences, and then outside country also these. And there is a debate between again in vivo, in vitro, or slit and the skit. Always, everywhere the debate is there basically. So you should attend, and then you should be able to know. So I'll hurriedly go, which I just told that we have the experience of SCIT for so many years, but it's not that the immunotherapy was not there in the ancient time. Ancient time, Vishkanya, these were the actually immunotherapy also. One of the literature I was reading last night, and I saw that the Buddhist monks basically used to be there in the forest and everything. So they used to get bitten by the snakes basically, snake. For the immunize them basically, so that in the forest if they are there, so the snake bites, then nothing going to happen. So these things were already there in the ancient time also. So we'll just hurriedly, I just wanted to put all the guidelines have advocated. Even I think Dr. Mahesh has very nicely told about why slit has been advocated in the GINA guidelines. There was a reason for that, which I think he explained very nicely. So all guidelines are there. So how it works, all the immunotherapy works, improve efficacy, sustains efficacy, long-term efficacy. It prevents new sensitization also. I think that was not covered. So if you do the immunotherapy in a one group, placebo and the immunotherapy, and after some times you will find that the sensitization has been less, new sensitization has been less in the group of the patient where the immunotherapy has been already given. And of course steroids reduction is there. Then the evidence of the early intervention, rhinitis already has been told that if you do a immunotherapy in case of the rhinitis, chances of development of the bronchial asthma becomes less basically. And if you practice immunotherapy and you stop the immunotherapy after 3 years, the efficacy remains for 10, and another data shows for 15 years. Efficacy in the prevention of new allergen sensitization, lot of data are there, lot of studies are there where sensitization has been reduced. Again, immunotherapy evidence based, so you have a evidence base about the bronchial reduction of the bronchial hyperreactivity, then lung function also, and so on. So in the pediatric group also a lot of studies are there. So they are safe, symptoms reduction, medication score reduction has been there. And there are very good study. If you see allergic rhinitis, the evidences are there. Very good evidence is there with the SCIT, and especially for the house dust. Lot of evidence is there for the house dust mite. That's very, very important. Lot of evidence is there for the house dust mite. If you see the evidence of the subcutaneous immunotherapy in case of the rhinitis, the evidence is much more compared to the asthma. If you see, if you compare between rhinitis and the asthma, the evidence is much more in the rhinitis group of the patients than the bronchial asthma patients. So this is also very, very important for the ENT people also to start in this field, basically immunotherapy and so on. If you see the SCIT and the slit in the allergic rhinitis, the evidence you can see is favors basically. The SCIT is favor than the slit in case of the rhinitis. There is a clear-cut meta-analysis are there. And if you see the evidence in the allergic rhinitis, SCIT still has much in allergic asthma. The SCIT prevails over the slit. And maybe, but new data are coming where the slit has also taken its importance and all those things. No, this slide is very, very important. Actually, I just wanted to show this slide. This is a very, very, very important slide where the meta-analysis was done, and that also house dust mite. So lot of evidence are there for the house dust mite basically. If you see, and then they have what they have done. A group A placebo, then the B they have given SCIT, they have given one, the 6 trials has been taken, then slit tablet is there and slit drop is there. So they have compared SCIT, slit tablet and drop also. So if you see in detail about this, if you see the symptom score, if you see slit basically compared to the placebo, slit tablet favors immunotherapy, yes, it works. Slit drop and slit tablet also, it also favors. And if you see the data basically, the favorable response is much more in case of the drops compared to the tablets. I'll show you later on. So, and if you see the skit basically, if you see in both, the skit has a more favorable response compared to the tablet and the drop. And but of course, they are all better than the placebo and they have a effect, whether it's a tablet, drop or the skit and so on. Now, if you see, only compare the slit drops with the placebo medication score, you have the very good response. Slit tablet, again, the response compared to the drops is less. Skit, better response than the tablet and the drop. And this slide, if you see here, symptom score, they have compared slit, drop, placebo. The effect is this much, good effect. This is tablet and the placebo. The effect is also good, but it's less. Skit, placebo, the best. Split, drops, and the tablet basically. The drop favors then the tablet if you see the literature and the meta-analysis and everything. So in the case of the medication score also, the process is almost the same basically. So if you see, the drops favors basically compared to the tablets. If you see the meta-analysis which I just wanted to put it. So all are effective. Again, this is the again, why only, I don't know whether you at the time you have seen this slide very nicely or not, why the GINA guidelines has given only the sublingual immunotherapy, not skit. There is a reason basically. Most of the data are there on the perennial house dust mite. So this study, if you see, subcutaneous immunotherapy, nose symptoms, skit better than the placebo, eye symptoms, slit better than the placebo, sublingual slit is better than the placebo, eye symptoms better than the placebo, and so on. And if you see the next slide basically, sublingual, if you see the sublingual immunotherapy and if you see the perennial means house dust mite basically, here sublingual immunotherapy in case of the medication, symptom score and the medication score, it is much better. If you see the seasonal, in the seasonal, if you see the subcutaneous immunotherapy is better than the sublingual immunotherapy. So maybe tomorrow, because maximum evidences are towards the house dust mite, so that's why GINA guideline have come out with the slit against the house dust mite. If they put it tomorrow, the pollens, so maybe they will put it skit is the better choice in the pollen. So that's the meta-analysis which has been shown. So with that, as per the literature, skit efficacy is slightly better because we know, and most of the studies are with the skit only. Safety 1+, slit efficacy 2+, and safety is the double plus. So it is safe basically to use either drops and the tablets. So the choice is basically your how to use it and everything. So with that background, I will just leave this and I will go to my talk which has been put it, that is about how to set up the clinic. So this will be just a repetition, setting up the allergy clinic. So almost all of you has seen the clinic basically. So I expect that you should have a better clinic than whatever we have at our Vallabhbhai Patel Chess Institute. And I'll be happy if I see anybody has a better, maybe you can have a center rather than the clinic. So, but if you want to open a clinic, I think allergy patients, basically, they always, you have to have a background in the mind that that should be a interdisciplinary diagnosis and the treatment. Actually, if you see, Vijay, if you see, we pulmonologists are taking care of only respiratory allergy. We are not thinking about the eye allergy. Rhinitis, at least we are thinking. We are not thinking of gastroallergy. We are not thinking of the skin allergy. So that also, I think we should always think, because the allergy is an allergy, rather than making it compartmental and everything. But anyway, so it's a interdisciplinary diagnosis and the treatment. So again, essential component is basically selection of the patient, preparation of the patient, preparation of antigen room, knowledge, emergency, all we have dealt with, preparation of the kit and everything, and the result. So requirement of the allergy center is basically I have tried to divide into 5 parts. One is the allergy diagnosis. So you need to do the proper diagnosis. So that is important. The second is educate your staff. So whenever you are going to have the clinic, you are going to have the staff basically. So I think always it's good that you have trained your staff who is doing the allergy testing and everything. And I think we have missed one thing, that is the proficiency test. All your staff should be advocated to the proficiency test, means every time they do the test, the variation should be not more than 20 to 30%. So that is acceptable. So that's why proficiency test is done, so that the variation whenever the staff is doing, maybe after 1 month or 2 months, so proper training to them. So variation of doing the test should not be more than 20 to 30%. That is acceptable as per the guidelines. So train them properly, because they are your first contact between patient and yourself. So rather for the history also, rather when they are going for the test also, because the technician is going to ask about the drugs and everything. If the patient has taken any drugs, the patient is empty stomach or full stomach, on all those things. So training of the staff is very, very important. Then deal with the adverse effect. You should have everything in the clinic so that you can deal with the adverse effect, educate and manage patients. I feel when you start any clinic, you should have a lot of pamphlets. You should make for the house dust mite, how it looks like, what is what are the avoidance factors you can inculcate to avoid the house dust mite. So all these things for individual, for the pollens, for the house dust mite, for the pet, for anything. So that should be kept in the reception, so that the person can see, can read at least. And then what is the procedure you are doing, how you are interpreting, what are the different kinds of the trees, tree pollen, weed pollen are there. So it's just a photograph. Some of the company has kept a beautiful photographs of all the pollens and everything. So you should make of your own, of the regional area and everything. So that will be, I think, the good. And then of course the allergy equipment and everything, which we have already discussed. So in the center, putting the patient first, the center should have provide the advanced updated care of the allergy, asthma and related conditions. So general principle is the world-class clinical care, emergency preparedness. Collaboration has to be there with your counterparts, like the skin specialist, then your ENT specialist, then gastro specialist, and then research. This I always that it's not necessary that you should be sitting in a institute to do the research. I feel all the medical practitioners can do the research. It's a simple way of doing the research. Rather, you can, if you want to make the software, you can make the software, or in the Excel format only. If you are going to put all the findings, patient name, age, sex, what are the symptoms are there, what is the diagnosis, what are the, if you have done the test and everything, what are the test positive, then which is correlating with the clinically, and then immunotherapy if you are giving, then how you are giving the immunotherapy, and every month if you are calling, or whatever the way you are doing it. So every time you write down what is the symptom score, what is the medication score. So if you put this also, and if you have 100 patients and you just make the result and then you can present anywhere, any conference also. I think this is the research. So I feel in that way you will be able to see yourself only what are the prevalent allergens in your particular area. And suppose all of you collate together all the results, that becomes I think the robust research of India from the different parts of the country. Nobody has. If everybody does 50 patients and just join hands together, it's a robust research. It can be published anywhere in any journal. So I feel research should be there at every clinic rather than only the institute people doing the research and all those things. Okay. Then of course clinical and the professional leadership is very, very important. Okay. Setting up the clinic, ideal if you want to have, then you should have a reception center, registration desk, and the waiting area, where I have told you that make some videos, keep it in the reception area. TB is going on, the patient who is waiting area, in the waiting area can see, keep some pamphlets there also, they can see, just like we have tried basically, but I think at the private you can do in a more efficient manner all these things. Then there should be a consultation room, and then after the patient has come to you, consultancy has been done, then you can have the skin prick test room, and then you can have a different room where the blood collection, or the same room as easily feasible. Then immunotherapy section, you can have a different section where you can keep the immunotherapy vials with you. The patient can sit down there, give the immunotherapy, ask the patient to sit down for some time, and then if you want to, if you are doing the pulmonary function test, you can have a facility for the pulmonary function test, and of course record keeping and the storage, another room should be there. So it all depends what is the infrastructure available at your place. So permutation and combination you can make, and you can create a infrastructure for the clinic also. Forms, booklets and the posters, you can make beautiful, and posters and everything, and I think that can be displayed at your place. Different forms are there, so that also you can keep, and one of the very, very important form is the consent form, and I told you earlier also, you can use these forms of the Patel Chess Institute. You can just omit the name of the institute and you can put your center's name. So all the forms should be readily available with you. Again, I am reminding you, consent form is very, 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 very important for you. Okay, and then the flow of the patient should be just like the flow for the other registration room, registration or the waiting area, and then after that the consultation room. Then after consultation, then the patient is thought of the allergy testing, then the allergy testing room, then the post-test evaluation. Again, the patient can come to you after the testing, because again the history has to be evaluated, it has to be correlated. So let the post-test evaluation should be have there, and if you want to do the other test and everything, so other test, the flow can be there. Then requirement for the allergy center, I have already told you about equipments and everything, blood pressure, spirometry, rhino if you want to do the rhinomanometry, and again I told you that whenever you are doing the test and everything, it's just a repetition but very, very important points. Whenever you are doing the allergy testing, the patient should be comfortable, you should be also comfortable, you should have an idea about the pollen calendar, and then you should have adequate light and the preparation of the antigen to which you are going to do the test. These are very, very important, and you can have different kind of the tables and chairs and everything, and the trays and everything. When I was actually, I took the photograph outside. When I was abroad, the people have a dental table basically. Dental table was like this, and very nicely the patient is relaxed, and you are doing the test. You can have the all the permutation combination. Ergonomics has to be seen, where the patient should be comfortable, and of course if you are doing the test should be comfortable, which these are the photographs. Of course oxygen, and if you have the bed also, that will be the best thing. And these are the photographs of our center. Again, I will not go about the needles. Already we have told 1 mm tip
needle should be there. You can use it, needle also 26.5 number needle can be used. If you want to do the specific IgE, again, you can have the instrument for doing the specific IgE at your center, prick to prick test facilities. If you want to create, you can create. If you are going to do the food challenge test and everything, of course, a separate section has to be there for the food challenge test, because making the recipe in that is very, very important. So for recipe making, you should have the kitchen and all those things should be there. So that is a separate infrastructure for that. Education material and everything, adverse effect, dealing with the adverse effect, then educating your staffs. Basically, I have told you the proficiency test. So the proficiency test, basically the variation should not be more than 30% and so on. And then of course the quality management is very, very important, the getting the quality of the allergens for the diagnostic and for the therapeutic purpose. For now, whatever the allergens are available, if you are using the one company's allergen, so please take for the immunotherapy for that particular allergen only. And Patel Chase does not advocate any of the company for your therapeutic or the diagnostic. I'll tell you, there are 5 companies which are there in our country. 3 companies are there in Delhi, so 2 companies have already stalls. 3rd company has not the stalls here. So that 3 companies are there. 2 companies are there in Mumbai, and then 1 company is there in Kerala. Any other company, you have idea any other company apart from this? This much only. So the other 5 companies are there in the market. You can choose anyone. They are equally good or equally bad, whatever you say. So, but having said that, the results are there. So we cannot say that they are not, the quality is not good. The quality is there. Maybe there is a batch to batch variation may be there, but of course you are getting the wheel formation, you are getting the effect of the immunotherapy. So all these things shows that the antigens are there, but yes, batch to batch variation may be a problem. That's right, Dr. Naveen? Maybe there, but still as a clinician I will tell you, if we are getting the results, so whatever is there is okay or good. That's right? Okay. So requirement of the allergy center. So I think preparation of the patient, again and again I am repeating the same thing and everything. And this already, I don't know, Dr. Virat, have you seen our allergy testing room? No. So this is our allergy, yeah. So waiting area, you can keep a waiting area, you can keep the television, you can keep the, rather you can have a more original grasses and everything that should be kept so that the person can see there. So this is the waiting area which has been made. You can have some posters also. But I will be happy if you collect the data and present it. If it is 50 also, 50 patients data, you should present in the conferences. At least in the Indian conferences, you can go, you can present it, so that you get the experience of presentation also, and plus you can show your data also, what you people are doing it. So I think with that was my aim, that in this way the clinic can be set up. You can have a better clinic than whatever you have. If anything you want to ask about the how to set up the clinic, so you can just ask me anything to be asked. You want to ask something? Yeah, Mike, go.
Sir, what are the common medico-legal challenges being as a private practitioner we can experience while practicing allergy first?
Okay.
And how to deal with it?
Yeah. So medico-legal challenges are not much. It is same as for the other branch of the medicine, or as a pulmonologist or ENT surgeon not doing the allergy practice. So all the challenges are same. Here the challenges may occur when you are using any antigen and anything happens, and if it goes to the legalities, then you must know everything, whatever you are doing is as per the government guidelines. Getting my point? So all should be as per the government. complication can occur. There is no problem. Complication occurs and complication can occur. There is absolutely no problem. Side effect can occur, anaphylaxis can occur, everything can occur. After a certain level, as a doctor, we don't have the control on anything. But the process which has been applied should be very clearly documented, and it should be robust enough to put it into the law. Yes, this was needed, I had this. This was needed, I had this. From where it has come, this is there. This is there. So all these things need to be there. That's all basically. Otherwise, it's a very safe practice. There is absolutely no problem. And we have not got any, except one patient when I told you that when we're doing the food allergy testing and anything, that anaphylaxis, much of the reactions are not there. It's a very safe. Having said that, side effects are there. To tell you basically, a lot of hue and cry is there about the side effect of, adverse effect of skit, literature. But when there is a adverse effect of the skit, it's documented. But if you go and read in between the lines of the paper, this was not because of any error of the allergen or any error of the doctor. It was the error on the hand of the staff dealing with the antigen. Wrong antigen was given and that adverse effect was there. That's right, Dr. Naveen? So that is the scenario. But as a whole, it comes as a adverse effect only. So these are very safe, but all the procedure should be very, there should not be any hidden thing which should be there, so that anytime anything happens, then you are not able to answer. The answer should be there for everything. Otherwise, there is absolutely no problem. Anything more? You got what I wanted to say.
House dust mite?
Any chemical? I don't know. There are many chemicals which are available in the market which you can spray for killing the house dust mite. Any idea about that?
Side effects. Because they are always chemical, and you are exposed throughout the night with that chemicals. So it is not recommended actually. Some of the companies they are doing, like the house dust mite, pest control is also done in India, some of the cities. So they are spraying it, but we don't recommend it because ultimately some of the bacterial flora also needed into the bed actually. There are studies done, healthy bacterial flora. So along with the dust mites, if you are killing the other bacterial flora, then the immunity also can be altered. So rather than the dust mite proof, bed coverings are more recommended.
And another thing is, there are many people who will get a problem with because with dhoop agarbatti, then your kachua chhap agarbatti, their smell and all those things. So all these things need to be avoided. Nothing has to be done against them basically. Yeah, you wanted to ask in. No, cotton mattress will have also the mites. That you can clean it. Mattress also you can put it into the sun basically. So if you put it maybe every 7 to 10 days or 15 days, I think that also works. Yeah. Linen and all those things should be put into the sun. We don't put it basically. We don't get time to put it, yeah.
Is there particular way?
No, nothing. You write it on your tablet, Sensumune 12 microgram OD for so many days. That's all basically. Nothing else.
For 3 years, for like.
No, you cannot write just now for 3 years. No.
1 month.
Yeah. Then you have to review the patient. No.
Yeah.
So no.
What should be the frequency basically?
No, you have to plan your maybe after every 3 weeks or 4 weeks, you ask the patient to come to your place. Then only you will be able to know whether the drug is working or not. So just like the other other prescription, and then you review. In this, review is very, very important because you are going to decrease the you step down the treatment for maybe rhinitis or the asthma. So the medication score and the symptom score, best thing for initiation of the practice, you should have a symptom score diary also. So what was the symptom, when was the symptom, was there any use of the SOS medication and everything. So when it comes on the paper, you can make your own day 1, day 2, day 3, day 4, day 15. If you want to review after 3 weeks, day 20 or 25. And some of the parameters you can put it: cough, breathlessness, if it is nasal irritation, sneezing and all those things, so how many times and everything, so you can put it everything. Then you should have a medication score. These are the medication you are taking, write all the names of the medication, and then the patient is taking whatever the medication he or she is taking, they should put it there only. Okay, SOS they are taking, so make a chart also, SOS they are taking. So as soon as the person comes to you, then you are able to understand, okay, this is the way basically. And in this way you can do the research also, absolutely no problem. All these symptom score, medication score are done by the daily diaries only. Even for the when you have done any thesis protocol, in that also you call every 15 days or 3 weeks or 1 month to do or review the patient basically. So in that way you can do it. Any more?
Sir, the people who are giving slit, I want to ask the people who are using slit basically, how are they writing the prescription? Slit.
Same thing, as sir said, there is nothing as such. We write like the dust mites is there. So we write like dust mites, okay, and so many drops for 1 month only, and then we call the patient back, because we have to analyze, we have to customize it. So suppose otherwise what happens, because of the weather change and all, exposure to the allergens or some infection happens, bad luck, they will blame the immunotherapy. So for that, the adherence of the patient is very important.
When you go back, whoever is practicing slit, when you go back, see your papers and the bills. I know the bills are given in a not to the patient's name, it is given in the doctor's name. That's right? Those who are practicing, the bill is given in the doctor's name.
Yes, sir.
See, slit is written or not. It will be not written. I'm 100% sure. It will be written only immunotherapy vial. That's all. That's right. No, you just see. You check your bill.
Sir, for sublingual, is it better to take empty stomach or like anything like?
Sublingual, I think you'll be better to tell basically.
We should not have anything, drops, and after also 2 to 3 hours we should not have. Tablet there is no problem. After half an hour you can have anything that. Before we should not have anything, and after that also 2 to 3 hours we should not have anything. Generally. It is because the drops absorption still nobody knows like how much. Yeah, night only. Most of the patients I give in night only.
So, Dr. Vyad, you are giving empty stomach.
Yes, sir.
Yeah. And tablets also empty stomach.
Tablet also empty stomach, half an hour before, nothing to be given.
Yeah. So we'll continue. Otherwise, it's 1 o'clock. I was thinking we'll finish by 12:30. So we'll have some time during the lunch time. We'll discuss. So I think the last lecture, which is to be specially for the pediatrician, this lecture is meant for the pediatrician because they should be also exposed. And Dr. Vijay is also the pediatrician. So I think pediatrics allergy, na? Pediatrics allergy.
Respiratory allergy in children. Sir. Yes, sir. Respiratory allergy in children, sir. Please. Thank you.
So this is the last but not the least, because as I mentioned, the most important is that if we manage the pediatric allergy properly, we can stop the progress of the disease. That's very important. So again, if you see the basic, we should remember that the prior exposure of the sensitizations, and as Rajkumar sir said, ki the sensitization, it happens over a period of time, and multiple sensitizations happen later on. So suppose the childhood asthma is there, and most of the children, they overcome the asthma, 80 to 85% of the children, and amongst that 90% have a underlying allergy. So the symptoms are overcome, but the disease continues with the newer sensitivities. So any doctor, means not only a pediatric patient or adult patient, always remember to pick up these early changes. That's very important. So from top to bottom, even the dandruff, seborrheic dermatitis, whatever we call, from hair loss to headache, migraine, ocular allergies, rubbing of eyes, nose and ears is a very common symptom. Most of the patients, even chuckling like this way, or sniffing, facial grimaces, sniffing inside, cervical lymphadenopathy, halitosis. Suppose the patient is sitting on the table or stool and if he is talking to you, the halitosis can be made. His breathing voice also, like whatever you can hear the breathing pattern, you can make it out obstructive. Then examine carefully the turbinates, deviated nasal septum, posterior pharyngeal hyperplasia, white coating of tongue, posterior, even the lymph nodes also. So these pick up like long eyelashes, wrinkling under the eyes or denim organ folds. This should be picked up in many of the patients because they will never say that they have allergy. Because recently I had one HOD of medicine from one of the medical college. And he had a significant urticaria. I asked any history of allergy or something. He said no. Then I just recorded him. Within half an hour, multiple times he has done this way. Okay. So that is one of the signs he is having a itching. And when I showed him, he had a significant turbinate hypertrophy. So it is a systemic disorder and it always progresses in spite of a symptomatic management. In between, the disease may be in the dormant stage or subclinical stage, but it continues to that. And as Rajkumar sir said, we have to explore a lot and we are learning. After so many years, we are learning this. So 2 years back when I had a lecture for chest physicians in Mumbai and the Harvard medical team had been there, Dr. Gitele, she is a pediatrician and allergy specialist. So I took some slides from her also. And there are studies done now, the environmental allergens are swallowed and they go to the gut mast cell and eosinophil sensitivity happens. And because of that, a lot of people, and in my practice also, how the subject happened, because when I discuss with her, so many patients of rhinitis, asthma, adults also, having a bloating, gaseous problem, gastritis, so many stomach problems. So she said that there are studies and I borrowed some slides from her also. So it's already 1/3 of the population is suffering. In cities, at least every second person is suffering with some or the other allergies. And as a practitioners, we may be a pediatrician, dermatologist, ENT, chest or anybody, or ophthalmologist. Our role should be to prevent the progression of the disease to the adulthood. So that should be the aim. So like my wife is an ophthalmologist, but now after practicing in allergies, she has changed the pattern. And now she is looking after the progress of the disease, hidden signs also. She is picking up, executing to the patients of ophthalmology. They come to her because it is a disease. As Rajkumar sir said, patient, we have to look into as a patient, not as a just nose or throat or eye or skin. And how we give so many vaccines nowadays, where at least one child up to 2 years, I think 20 to 40,000 rupees vaccines we are giving to the child. But here, this is a very severe progressive disease and it is causing so many complications of adulthood. So the central part is a allergic rhinitis, and related to that, many of the things are there. So inflammation underlying, and then the comorbidities also should be seen while practicing. And then the lifestyle also is very important, even sunlight. As somebody said, what to do about the beds. The people don't go for a vitamin D also into the sunlight. That's a problem nowadays. So considering, so this slide I borrowed from Dr. Anne from USA. See, so many patients are going into COPD. So now again asthma COPD overlap, multiple factors are there. So rhinitis is a central part, and amongst that 40% of children. Recently we published data in one of the pediatric pulmonology journal. 50% of the children are having a rhinitis now in Indian scenario. They go on rubbing eyes or ears and all. And the blocked nose, the disturbed one, again post-COVID you must have seen in your practice, if somebody is a pediatrician, a lot of adenoids have increased, open mouth breathing, snoring into the children. So these are Th2 inflammation was already there. The mast cell activation has happened, late phase reaction because of the COVID virus. So post-COVID, a lot of inflammatory viruses as a practitioner I am seeing in children also. So recently, just this year only published data about, this is a simple score where we can analyze the allergic rhinitis into the population. Even PubMed also has published an article on that, and this can be used in our practices. 90% of the children with asthma, pediatric asthma, also have an underlying allergy. And I will not go into the details of the allergens. Already in Pune, we did a studies on molds. Now we are doing a pollen studies also in Pune. So the molds were found in many places, specifically children's, their bathroom of the schools. And the children eat anything and the food particles fall into the deep corners. And then from all the age groups we did a data, dust mite, pollens, molds was significant also, and pigeon feather and dropping is a significant allergy. The feathers are contaminated with 17 types of dust mites. So even if they are outside or the unit of the AC, the dust mites can travel inside in the house and they will contaminate that way. So as the child grows, they will develop a multiple sensitivities in spite of a symptomatic control. Suppose atopic dermatitis control, asthma, rhinitis or allergic conjunctivitis is very common in children. It is controlled as most of the ophthalmologists, they say that as the child will grow, he will overcome the eye allergy. The eye allergy will go away, but his other complications will happen with the deviated nasal septum, then snoring or adult asthma, chronic respiratory disease, sinusitis. So rhinosinusitis, rhinotitis, rhinobronchitis, that way. So they club up and then they will have a problem. So the traditional, whatever the practices are happening, so many of the parents will ask, why not to use a massage of basin or something? Because the genetic pattern has changed. So these massages are also causing a sensitization of the dendritic cells from the skin, and they are sensitizing. That's why now a lot of food allergies have also increased in children. Previously, hardly in a 6 months, I used to have one child with anaphylaxis. Now in a week, I am having 1 or 2 patients, specifically with the severe food or drug allergies, specifically in children. So these cases are increasing now because the traditional things has to be changed. So again, the morbidities, we have to see repeated respiratory infection. There is a real-time data now. It has shown that repeated respiratory infection also in upper airway, it's Th2 inflammation in real-time data, and 80% of the patients may be a underlying inflammation. So as I mentioned, these we have to pick it up early so that you can see 320 millimeter of mercury pressure happens into the eyes. It is very dangerous. So we are getting a lot of these keratoconus cases. Previously, hardly within a year, 2 to 3 patients used to be. Now, within 15 days, 2 cases of keratoconus we are having at the age of 17, 23 years. So these complications, then early age cataract glaucoma because of the repeated eye steroids. See, the nasal steroids and inhaled steroids don't have much side effects. But the skin steroids, like whatever the ointments and creams are used, or the eye drops, have a lot of side effects. Recently, one of the patient had been to USA shifted, and she has been given by a dermatologist fluticasone gel, and she showed over there. So the doctor over there said, you continue this, but he prescribed down below his prescription. He has written it can cause a bony problems, it can have a cataract and all, even with the gel. So they are so particular about that because the absorption happens through the skin, and skin is the second mouth of our body. Okay, so whatever it is applied, so nowadays even the so many perfumes and all, the fragrance free, the creams, gels, so many things, the facials or the beautified products, also it is written nowadays. So the eyes, they have a lot of problem. This young child had an early age cataract also significant, and you can see the allergic march. This is very important. So this child was treated symptomatically with inhaler, nasal sprays and some precautions, but he went into the periocular eczema and VKC also. So this allergic march should be stopped as a pediatrician, and it impact the quality of life. 2017, I presented a paper in Canada on systemic effects of allergy. So we found that many of these patients are given a first generation antihistamines, and they have a lot of impact to the children. So already the rhinitis, which is obstructing, causing a respiratory acidosis and causing a impact to his ADHD and behavioral disturbances. And on top of that, these first generation antihistaminics are given. In USA and all, below 12 years, the FDA has banned the first generation antihistaminics. In USA, there was a study done, 78% of the adults, also drivers, whatever the medicines they consumed, and they had accidents. Amongst that, most of them, there also they are getting over-the-counter CPM. In Indian scenario, the drivers, if they have accident, only alcohol level is checked. So we don't know. So our drivers already have one medicine, and on top of that, if they have a sinus 77 in arrest, what will happen? So So direct and indirect effects to these are much. So then, as I mentioned, these environmental allergens are swallowed and they cause the gut inflammation also. And there is a gut brain, gut lung, gut skin axis. So these are also there. So the barrier improvement is also important. So in pediatric age group, specifically in atopic dermatitis, and if the patient has a comorbidity, we are using a probiotics also in our practice to control the inflammation overall. Even there are two thoughts of studies. When I was working with the World Allergy Organization Allergy Prevention Committee, there even the third trimester, if the mother is supplemented with some probiotics, it can be useful to the children to have a lesser severity, the duration of the allergy will be less, and it may be the late phase rather than the early age allergies into the child. So these are the cases. I will not go into the details and whom to be tested for the allergy testing. And 90% of the children with asthma will show some or the other positivity with the allergen sensitivity. Then, as previously Dr. Siddharth also said, the pheno is very useful in pediatric practice. I am doing a clinical trials in asthma, pediatric asthma. So we have done that. Oscillometry also now is a very good in pediatric asthma patients. We can pick it up some patients because the people, they will always feel that the child has a lesser severity. They will be happy. They want to stop the inhalers. So most of the patients come to me to stop the inhalers. They feel like after going to here, they will stop the inhalers. So we should guide them. We should not stop it hurriedly. Always do the oscillometry or pheno, check the inflammation because the underlying inflammation should come down. Otherwise, then again the exacerbation can be there, and that inflammation will continue, and later on it will have problems into the adulthood. So the pheno, the XL nitric oxide, which will pick up the eosinophil inflammation into the airways. So these are the how the levels into the children. So above 20 is significant. Adolescents also 35 above, it is significant. Adults, if it's more than 50, it is more significant that way. So the allergen avoidance is very important in all allergic cases. Besides that, then the symptomatic management is different. But the first should be the allergen avoidance. So even there are studies done, as I am working with the American Environmental Committee, a lot of discussions happen. So now if you see in India, we are treating at this level. Even the biologics are also very less used. Immunotherapy is hardly used. But the exposure to the allergens, if we guide, many of the patients will have a lot of benefits to them. Immunotherapy and all is later on, but at least the avoidance measures should be done. So then this gut allergy collection should be kept in the mind while treating the patients. So some of the patients integratedly we require, specifically in pediatrics, we give a zinc also, some antioxidants as well as vitamin D3, calcium supplementation also, and probiotics to reduce the gut inflammation. So probiotics, they have shown a very good basically relief to the patients for the gut inflammation, and as there is a connection with different organs because of that, they help the patients. So how they have action that to reduce the infections repeatedly, because improving the IgA phagocytosis, increase the Th1 response and interferon gamma and TNF beta, and reducing the IL4, IL5, 13. So there are some studies done. So as a supportive way, it is not the drug, but as a supportive it can use to reduce the repeated steroids, we can say. So pharmacological, children specifically, the second generation antihistaminics should be prescribed. Now 80% of the patients are given a first generation antihistaminics. Recently I had one gastroenterologist child, and the psychiatrist said ki because of the first generation antihistaminic, your child is having more ADHD. So the child had been from Mumbai to me in Pune, and when we analyzed, repeatedly he was given the CPM combination. So it should not be given, always second generation. And the levocetirizine is also very good. It's cheaper also in most of the patients. Some of the patients, cetirizine also is very tolerated very well for atopic dermatitis and all. Then the fexofenadine, desloratadine, bilastine, about 2 years it is recommended now. So oral decongestant should not be because the palpitations and tachycardia and other things are there. Very few patients about 12 years we can use it. Localized azelastine can be given if it is a severe ocular allergy. That is the only recommendation where we can use for 1 month to 3 months also azelastine nasal steroids along with the nasal steroids. So the technique is more important rather than just because many of the children, if they give directly, they will have a bitterness into the posterior and oral problem, and then they will stop the treatment. So we have to remember this, how the sensitization happens in children with all these massages and all. Most of the children, they play with the mother or grandmother, and they are also playing with the vegetables, grains. So the sensitization happen from there. Then the oral intolerance happens, and then systemic reactions from the other parts of the body. So recently I had a child, they did a interleukins in USA and the basophil and mast cell activation test. So in future in India also we will be having these tests, and which we will have a targeted therapies in children also, because we can stop the inflammation and further progress. In Pune we did severe asthma allergy patients with the National Cell Science Laboratory, and significantly 80 to 85% of the patients we found a significant Th2 and interleukin raised in their serums. So this was a Kashina 12-year-old child with a severe asthma with comorbid. He had atopic dermatitis and ocular allergy also, and because of the repeated steroids and all, his weight was very high. In one of the institute, the omalizumab had been already given for 6 months. He was not having a good relief. So the father wanted to stop. They were affordable. The father had also a history of snoring. The mother had a eczema. Sister had rhinoconjunctivitis. And the child had all hidden signs of allergy. You can see over here. His PPB level, PNO was high, IG was high, AEC was 1250. And comparison to that, documented dust mites, and on the history also, when he used to go playing the football and all, he used to get a significant trigger. So then this child, we started on a benralizumab, and it worked a miracle to the child, and he had a very good response. Even one of the cardiothoracic surgeon from Aurangabad, we used the benralizumab, and his quality of life improved a lot. So while practicing, we have to assess the children, and like omalizumab already Dr. Siddharth talked a lot, but urticaria in children, we have used many patients and we have found a very good results. Ocular allergies, more than 550 patients who use the omalizumab, and their steroids went down, their rubbing, and even one child had been operated for at the age of 19 years for the glaucoma, and to save the another eye, we use the omalizumab. So even the cytokine levels also can be analyzed into the tears of the children. So these are the future, like probiotics, biologics, and immunotherapy, and they will really help to the patients. So this is a CRD, component dissolved diagnosis. In children specifically, some of the children with asthma may have a severe anaphylaxis. I have few patients where they were just treating as an asthma, but one fine day they had a significant anaphylaxis. One 17-year-old girl was there, she ate some sushi, and she was rushed to the hospital with a prawns anaphylaxis, because there is a cross reactivity with tropomycin of prawns with the DERP1, DERP2 of dust mite. So they may overreact one fine day with some of the foods. So these cases specifically, we can do and most of the pediatric parents, they will always say they will stop so many foods, so the nutrition is affected. For some of that reason, we can do the CRT and show them that your child don't have a food allergies, because hardly 2 to 5% of the pediatric population have a food allergy. Otherwise, it may be the oral food allergy syndrome. It is like a cross reactivity or gut inflammation, which will be just triggered by the histamine into the besan or lentils and all, and the parents will blame the food. Or latex sensitivity has a cross reactivity with the fruits like banana, avocado and all. So that way we have to show the parents that it is not a food allergy, so the nutrition of the child should not be affected. So there we can do this component dissolved diagnosis. So, and some of the patients with the insect anaphylaxis, if it is there, then the CRD is very useful when desensitizing these patients. So you can see, like, the egg is there, the GALD1, 2, 3 antigens can also be analyzed. So I will not go into the details of that, but in an early pediatric age group, if you can manage this Th2 inflammation, because as the child is born, he is predominant with the Th2 inflammation, because Th2 inflammation during the pregnancy has some benefits to the mother. That's why it is there. So the child is born with the Th2 inflammation predominant. As he grows and if he is naturally exposed to the infections, his Th2 will come down and his Th1 will improve. But because of the nuclear families, the cesarean born babies, and early age bacterial infections because of the nurseries and all, the Th2 inflammation is predominant, and use of antibiotics and NSAIDs into the infancy, they are altering the bacterial flora, and the Th2 inflammation is predominant. So if you manage with the desensitization early stage, the Th2 suppression will be there, Th1 improvement will be there, so the secondary infections also go down, so the tonsils, adenoids and all. Very few patients really require a surgery for the tonsil adenoids or DNS, because if it is a significant sleep apnea, after demonstrating with the sleep study or with the rhinoscopy, then only we should operate, otherwise there is no need. Whatever the allergy was arrested over here, we have seen practically, and there are studies also done now. It has been found that if hurriedly and haphazardly these patients are operated, they will develop early rhinoconjunctivitis, rhinosinusitis or rhinobronchitis with a severe way. So rather than that, we manage that. So allergen immunotherapy, I think already the previous speaker has already spoken about that. We should see that, assess the patient after 6 months, 1 year. If it is not working beyond 1 year, then drop it. Assess it, any precautions, anything is missing, then drop it. If it is not working, some of the patients, 20 to 25% patients don't work also. So stop it. Then, as I mentioned, in pediatric population, the significant food allergy, if it is there, we have to always give the EpiPen also with the parents. We don't have EpiPen available, so I think it has been already told you how to prepare it. Again, the preventive approaches, the cow dung exposure as well as the farm dust exposure is helpful to prevent the allergies. So problem is in India is that so much pesticides are used, the natural farm dust is not there. Otherwise, in European countries, if you go on the Amazon, the farm dust capsules are sold actually. So how to hygiene theory, so let the child have a natural infection. So many parents, they give amoxicillin, azithromycin routinely at house. They should not be promoted. Tell them that you are killing the Th1 immunity, and Th2 inflammation will be increased because of that. So don't give that. Most of the viral infections, they settle down, so they will have a more Th1 response. So in pediatric allergy, it is already a chronic disease. It is increasing day by day. Most of the adults with allergies, asthma have a beginning in the childhood. Our aim is to stop the allergic march leading to the complications over there, and proper allergy tests and the approach with the precautions. Even the long term wise, most of the parents will, they say ki so much costly. The long term wise, the cost is less than whatever they are taking a treatment. And we should have a coordination with the gynecologist. So now the time has come to prevent the allergies even to the next generations. So we should educate to the gynecologist also. Once the mother is registered with the gynecologist, the family should be registered to the pediatrician also, so that we can guide them better and we can prevent the allergic march into their children. Because children suffer a lot than adults, and their quality of life suffers. Thank you.
Thank you, sir. Thank you for a very engaging lecture. Any questions from anybody?
At present, proven one are Lactobacillus rhamnosus GG in atopic dermatitis. Rest of the other respiratory probiotics and all, the trials are happening, or even against the specific IgE. Now I am doing one of the trial of one of the company for how we can reduce the IgEs. We are doing that. So once the trials will be there, then that way.
So, sir, what is the regime you are following with the probiotic?
Daily Lactobacillus rhamnosus GG, one sachet is there.
One sachet daily?
Daily, below 12 years sachet, and above 12 years capsules are also available.
1 month or 2 months?
At least 3 months to 6 months. In an allergy point of view.
Okay,
Yeah.
daily for 6 months, and then any alternate day therapy also?
No,
Nothing like
we should stop it. Most of the patients, what I do is that during the season, like most of the atopic dermatitis, they have a seasonal exacerbations. So before that, only 15 days before the winter season, I start on them that way.
You told, how are you practicing it? Like for pheno, you call the patient after 3 months and then you see the levels, and according to your stepping down
Generally,
the something?
after 6 months interval, because that season has to go on. I mean, because immediately we will not have that much response. So generally after 6 months. And it's better way to call before the season and after the season. So it will be much.
Okay, sir. What is the propensity for atopic dermatitis going to allergic march? It is similar to allergic rhinitis.
50% of the children with atopic dermatitis have asthma. 50%. And others like sinusitis, conjunctivitis, it's higher only. It's more.
Thank you, sir.
Yes, thank you.
Sir, is there any method like if child is genetically predisposed, like both parents have issues of allergy, so child doesn't develop allergy, is there any preventive method like?
As I said, the research is happening and it has shown there are two thoughts. So one thought, it has been already said, like if the parents are treated properly with even the desensitization and all, the child will not have that much severe allergies. He will have the allergy, but not that much severe. And it will be a late allergy rather than an early childhood. Like we are seeing a lot of eczemas now, a lot of food allergies in the children. Why? Because the parents were not treated properly. So that way it helps. Even as Rajkumar sir said, so luckily last 27 years I am keeping all the records. So I have a data. So I have seen that. So many of the parents, the elderly sibling had a severe asthma. And during the pregnancy, we did a testing to the mother. We guided her what precautions and all. The next child did not have that much severe allergy. They developed at the age of 12 years, 15 years, some eczema or some rhinitis and all. So that also is very important. The severity also will be less. Yes.
What antihistamine will you advise in below 1 year? First 1 year.
Below 6 months, though, they don't need only. From 6 months to 1 year, cetirizine is very good.
Thank you, sir. Thank you for engaging talk.
Thank you very much, sir. I am requesting our director, sir, to please felicitate Dr. Vijay Varad, sir.
डॉक्टर सिद्धार्थ राज यादव अभी सबको नहीं मिले विदुषी डॉक्टर विदुषी राज मैं अपनी जगह पे चले जाऊँ
in my sleep.
So I think we are at the end. So quickly, because I know many people have to take their flights and everything. So we'll quickly first distribute the certificates, I think. And then after that we have few talks. So that in that way, and then you take your lunch and then you will close the session. So, okay. So I think, isko na idhar kar do. Manoj? So I think I request all the faculty members to come on the dais and we'll just distribute the certificate. Dr. Naveen, come. Dr. Nitin, Dr. Siddharth, Vidushi, Vijay, come. Should be the part in the certificate distribution. Yeah. So I think somebody has to call. कौन कर रहा है कोऑर्डिनेट कौन कर रहा है हाँ मनोज चोपड़ा So I think we are giving alphabetically, so be prepared.
Yes, ma'am. Wait, sir. Sir.
Dr. Aditya Sharma. Ajay Garg.
Sir. Yes.
Dr. Akshi Singhal. Dr. Amey Vikram Rathod. Dr. Ankur. Dr. Ankur Nik. Dr. Archisaman Bhattacharya. Dr. Asutosh Chaturvedi. Dr. Ashutosh Chaturvedi. Dr. Avinash Kumar. Dr. Bhanushali Deepak. Dr. Bhutani Nitin. Dr. Chirag. Dr. Faruqi Shabina. Dr. Gunjan. Dr. Hari Kishan Dwivedi. Dr. Jitendra Rajput. Dr. Joshi Ansu. Dr. Kirti Agrawal. Dr. Kashmira Shilpa. Dr. Kuljit Singh. Dr. Lalit Wadhwan. Dr. Makadia Vivek. Dr. Manish Yadav. Dr. Melba Napoleon. Dr. Mukul Pandey.
Dr. Naresh Chandra. Dr. Prachi. Dr. Prachi Gupta. Dr. Raut Ashwani. Dr. Richa Thukral. Dr. Ritika Gupta. Dr. Salman Khan. Dr. Sheru Singh Rajput. Dr. Singhi Kripa. Dr. Suman Seal. Dr. Shushan KS. Dr. Yogesh Kumari. Dr. Jeenat Sultana. That's all, sir. Okay, sir. Yeah, yes, sir.
Yeah, another 5 minutes before we end basically. किसी और का है क्या? So another 5 minutes, just 5 minutes bear with us. And I think I will request all the faculty member to just say the few words, last few words, and then we'll give an opportunity for you to also interact, and then after that wind up. So I will start with Vidushi. Mike. Vidushi, mic. Vidushi.
Thank you, sir. So it was a wonderful 1 week experience with you all, and happy Teachers' Day to all of you. We hope that we could impart you something that you could practice, and simultaneously we have also learned. I personally feel that I have learned a lot from your experiences also. Your questions, your experiences also help us grow, and hope you can practice whatever we have managed to impart to you. Thank you.
Dr. Siddharth.
Happy Teachers' Day to all of you, and a very apt day actually, because we all see the further research after standing on shoulders of our teachers, and I do believe you people will stand over our shoulders and see much further in the field of allergy. So all the best. May God bless.
Dr. Sonam.
Good afternoon to all. It is a wonderful 5-day with all of you. You are all eager to learn the allergy diagnosis, allergy immunotherapy, and hope we little bit do. Although it is just a sensitization, nobody will become an allergologist in 5 days. We are still learning also. And my request is to just judiciously use the allergy, not to misuse, overuse it. as we are very bad name to overuse and underuse it. So with this, best of wishes for all of you.
Dr. Nitin.
So first of all, happy Teachers Day to all of you also. And it's been a brilliant learning experience, I believe, for you all and also for us. And I wish you all the best in your journey of allergy practice, and be judicious and be ethical. That's my wish for you. Thank you.
Dr. Naveen.
Yeah, congratulations to all of you for completing the course, and good luck for the future. Thanks.
Dr. Viran.
First of all, happy Teachers Day to all of you. And you are learning from one of the best institute in India. That's a very good thing. Because when I was in Bombay, I was not knowing, frankly speaking, that time VP just had the courses and all. So we had to go out and we had to learn it. We spent so much money and all. And Indian perspective, whatever the data the VP chest has, because each and every time when I come over here, I learn a lot. And whatever, like last many years, I am seeing VP chest. And I always say कि जो राजा आदमी से आप सीखने को मिल रहा है डॉक्टर राजकुमार सर, he has so much experience in this field, and whenever I come here, I learn a lot from all of these people. Like just now I told Siddharth ki like your previous presentation, now this year's presentation was much better. Everyone like Dr. Sonam and I saw. So there's so much research is happening, and as Rajkumar sir said, ki like you start doing it slowly, go slow, it's better. So don't look it as a commercial purpose, look it as a community purpose, I will say. It's a benefit to the community. Community requires allergy specialist. See, community requires the allergy specialist. That's very important. So always, again and again come here, learn the things, send more people, because it is needed to the community. Thank you, thanks a lot.
Thank you. So any participant wants to give any suggestion, any constructive criticism also is welcome. There is absolutely no problem, because we also learn from you people only, and when we prepare anything, we also go into detail about the questions, what can be there, what can be the answers for that. So anything you can talk, you can criticize also. We'll take it as a open heart, and we'll try to improve for the next time. That is the basic purpose of whole our team. So anyone who wants to say anything, they welcome, please. Yeah, mic दीजिए वहीं उधर ही दीजिए.
Good afternoon, everyone, and what an auspicious day today with so many great teachers and so many great fellows, and everybody here is a teacher. Our patients are our best teachers, actually, what I believe. And wonderful workshop for last 5 days, where we have learned so much. And as a pediatrician, it is my job and it is my responsibility to, halt the allergic march. And we see so many patients right from the infancy, in fact, right from the, birth, starting from evening colics, starting from atopy and all those things. So it is my responsibility, and now I will be more responsible and I will be more sensitive. Allergy is a sensitive topic, so I'll be more sensitive enough now to be using these tools and using these knowledge and wisdom in my patients, and more better counseling I can do, more I'm able to convince them more for these tests and these tools, so that I can treat them better and to make a healthy and better future for them. Thank you so much, sir. And one just a little bit of this, that I want for the next time we should be involved more in these lectures and these type of CMEs and workshops, and more of case scenarios, I would say. And we should be also being able to give the chance to present the cases, so that we are more able to be more efficient in taking the history, because history is such an important aspect of allergy. So that feedback I would like to give, and rest everything is, I think, no doubt about it. It's wonderful. Thank you so much. Thank you.
Thank you so much. In fact, we were thinking of dividing into groups and giving you the case scenario, and then should prepare in the night, and then you come and present. It was there in my mind, but somehow the other it was not implemented, because we went so late and everything and tired. But yes, from the next time, this is a very good suggestion which will be implemented. Definitely will be implemented. Thanks. Anyone else?
Sir, it was a really a very good academic feast. We could learn a lot, which we will try to do practice in our this thing. One small suggestion is, sir, ki, once we are getting the mail, if we also that time we come to know ki accommodation is available in the hostel, so we will not have to look for hotels nearby, because some few people are staying in hostel, Delhi University hostel, so we never knew ki this facility is available, so we had to look for hotels outside. So that is the small request.
Yeah. So basically what happens, the accommodation is always a problem, because this is a big university, and sometimes you get, sometimes once what had happened, we had kept 10 rooms, 10 or 15 rooms, and suddenly 2 days before the notice came, all the rooms are cancelled. So we thought what will happen. So somehow the other that time we managed. So that's the reason basically we are not keeping the accommodation, we are not taking care of the accommodation. But still anybody wants basically, and especially for the female candidate, anybody wants that accommodation need to be given, it's our duty to give. But yes, we'll keep this thing in the mind basically, but there is a limitation of the organizers rather I can tell. Okay, but certainly we'll keep into the mind, but definitely we always try that at least for the female candidate there should be a safe stay, should be there. That's our thought always. Yeah.
That was a wonderful course. Thank you very much. And previously my attitude was like whenever there is nasal allergy which we can't tackle in the normal way, just refer it to the allergy clinic, then forget about it. They never came back also. Now I think I can on up my cases. I can ask them to bring back the results because I can read it now, and I'll be able to on up and I will be able to guide the treatment. Thank you so much. And I wish we could add a few more ENT related topics next time.
Yeah, definitely. We understand, madam, because you are at a good hospital, you are doing good work also, and allergy is a part. I feel there are many things are expected from the hospital, and especially you people working at a different department, at a different level. We had an idea that the pediatrician will come. We never had an idea that now the penetration is towards the ENT people. We heard sometimes 1, 2 were there, but this time almost 50% of the people are ENT people. So definitely more and more. Otherwise we were happy with, frankly speaking, Achalji giving the lecture, everybody is happy, we are also happy, we are very happy on that. But definitely from the next time basically we will keep the people who are in the ENT practice and who are also inclined, if we are able to find out an ENT person who is doing allergy practicing, we'll try to find out. Very less people are there.
Why we have come in large numbers is because we feel the need for it.
100%.
Because now is the time we have started feeling the need to know more about allergy. We should have the basic knowledge, then only we can build up.
नहीं तो मैडम और राइनाइटिस ना पल्मोनोलॉजिस्ट वालों ने लेकर के रखा हुआ है अपने पास अगर अभी से
No, we get only the bad cases, like where
that's why no, so हमसे ठीक नहीं हुआ तो हमने लगे एक दफे
when there is no other way then we get
ENT वालों की ओपिनियन लेकर के आओ. We do that at the lighter joke. But now seriousness is there, I understand, and definitely means I'm going to work to find out. आप बताइएगा कोई जो ENT के practice कर रहे हो or towards the allergy, because he will have more experience and everything. So that's a very good data. I am telling you, all the ENT people, rather there should be a branch, surgical and the medical branch, because all the datas are, very good datas are there for the rhinitis patients. Very good, excellent data. This is peanut what we have told you. You must go and see. Means 99% datas are rhinitis. And rhinitis and the ENT people can at least stop the progression to the bronchial asthma patient.
70 to 80% of the people of the rhinitis is ultimately going to land up with the bronchial asthma. We ignore common cold, nasal blockage. We just ignore. The patient will tell only when the cough has started, then only come to the when you ask the history, कितने दिन से प्रॉब्लम है, 2-4 दिन, 10 दिन, 1 महीने, 2 महीने, go to the exact history, 20 years से उसको प्रॉब्लम है. अब उसको क्योंकि नेचुरल हिस्ट्री इज गोइंग टू गो टू अस द ब्रोंकियल आस्थमा, कफ आना शुरू हो गया तो उसको टेंशन होना शुरू हो गया, देन दे विल रन टू द ENT पीपल और दे विल रन टू द pulmonologist. Certainly will take care of whatever your advice is there. Anyone?
First of all, happy Teachers' Day to all. Sir, from my side, no suggestion or criticism, as I've personally felt everything was very well managed. Just a review that before coming here, we were like an empty utensil as far as allergy was concerned. Now at least we are half full. The remaining half, I personally believe, is a lifelong learning process which we have to do. So thank you for this workshop.
Yeah, 100% is say we are also learning. You know, daily the things are changing basically. Yeah.
This is from all of us. Good afternoon, everyone. It is indeed a great pleasure and privilege for all of us to have attended this great and rare academic feast. We find ourselves short of words to thank everyone who has directly or indirectly helped us, all of us, to enjoy and gain the treasure of knowledge and we received here. Gagar mein sagar is the word very apt to use here. In 5 days of short period, we all could get a good insight into noob and corners of allergy and its practice. Teachers of the teacher, Dr. Rajkumar sir, thank you so much. And your team, Parul ma'am, Vidushi ma'am, Nitin sir, Sonam sir, and Siddharth sir, thank you so much. Incidentally, today happens to be Teachers' Day. So happy Teachers' Day to all of you. We all express our deep sense of gratitude and thanks to all the faculty who have made this a memorable learning experience for all of us. Thank you again. And just a token of respect from us, sir, please. Just a gratitude, sir. Thank you so much. We are overwhelmed. Sir, please. Ma'am. And the sweets. So shall I bring the sweets right there?
Thank you so much for the love and affection you have shown basically, and whatever we have done from our core of the heart basically, and it was just a mission of the Patel Chase Institute that education has to be imparted, and definitely there was a demand from the ENT people also that there should be a training course for the ENT people. I give you the word that we'll definitely do, and we'll allow for any of the training programs which we do for the bronchoscopy. Okay, Ajay? नहीं, जो छोटे भी करते हैं तो उसमें भी जैसे हम लोग केवल पल्मोनोलॉजिस्ट को बुलाते हैं, बट द बेसिक ब्रोंकोस्कोपी एंड ऑल दोस थिंग्स शुड बी ऑल्सो, एलिजिबिलिटी विल बी, इसको एलिजिबिलिटी में डाल दीजिएगा, है ना, डाल दीजिएगा ENT पीपल के लिए. सो डेफिनेटली विल डू इट, देयर इज नो प्रॉब्लम. अनदर थिंग, इफ यू रियली, देयर आर मेनी कोर्सेस, लगता है किसी को घर जाने का मन नहीं है, लगता है नहीं. I thought 12 o'clock, 12:30 I will finish everything, but somehow they say, just say your enthusiasm and affection. So for the knowledge sake, We have we conduct the courses like 1 day, 2 day for the bronchoscopy also. But anybody, if they are interested, basically they can go to the site also. They can contact any of our faculty member. We have the different courses for the doctors also, like 1 month course for the allergy, maybe 1 month course for the bronchoscopy, then pulmonary function test also. So different courses are there already, and those courses are on the website there. But even if you, for everyone, even if you just write a mail that we want to have a observership for maybe 15 days, 2 weeks, 3 weeks, 4 weeks, we 99.9% we allow. So there are many pediatricians who have done the different courses. They approached me, ki, sir, we want to have some observership for 1 month or so. So we allowed them also. They sat down with us in the OPD also. So, all the permutation combination can be done. Only we see that how much enthusiastic the person is. So that is there. Anyone wants to say anything more so that we can just wind up, because something is going on in my mind, so finish it off. Anyone? So nothing. Then before I conclude, I just want to put on record basically the people, pharmaceutical companies also, because without them these process are not possible. They help us for the academic program. I'm not promoting any companies, again I'm telling, but yes, as a token of respect, basically we want to just want to felicitate them also on the dais. So I request Sonam to call the representatives.
Alcure Pharmaceutical Company. Lupin. McLeod Pharmaceutical. Alvec. Any person from Alvec? Alvec. Any person from Alvec? ZS Healthcare. Anyone from ZS? Sun Pharmaceutical Industry Limited. Alvex. Sun Pharmaceutical Industry Limited. Cipla. Anyone from Cipla? That's all, sir.
So I will just 1 minute I will say. So as thank you so much, and as a concluding remark, this is just a sensitization of allergy and immunotherapy. Yes, rightly told that still we are learning. I am also learning, and And lot of things are to be learned basically. In the allergy practice, what is right, what is wrong, you do not know. Today it may be right, tomorrow it will be wrong. So there are many things. Last year I read something else, today same thing I am speaking something else. So it's always learning and everything, but only thing I will suggestion is that you people should go back at your place, try to do at least still allergy testing. I think that much you can do. And then some of the cases you start with the immunotherapy, whatever the way, whatever the route you think is the best, all the routes are fine for the patient basically. There is absolutely no problem. Academics is slightly different, the practical thing is slightly different and so on. So I wish you all very, very happy journey, because I know basically that when you go out for 4 or 5 days away from your family, you stop your practice, you are losing money also. If you see basically, you stop your practice, leave near and dears and come to the hospital like this. So we have also a human touch that we also understand, and we didn't wasted a single minute of yours, because I understand leaving everything, coming to the institute. So that is the basically core of everything, and that is the reason I was always there in this hall only, so that not a single time should be wasted, because the time is very, very important. And time is very, very important. So we have the academics, but we have the human touch also side by side. Because I feel always that if the person is a good human being, he can become good doctor, engineer, anything. The first is the human being. If you are a good human being, you can be a good businessman. All the businessmen, top businessmen have a good heart also, what I have seen basically. So with that remark, I pray to the God that you are success in your venture, new venture you have started. And of course, everybody is a teacher. So wish you a very, very happy Teachers' Day, and wish you a very, very happy and safe journey to your place. Thank you so much. And with that remark, one thing, our whole, because all the faculties are there, but apart from the faculty, there are many people who work behind the scene and they are not recognized. So I will request all of the people who are working behind the scene, which nobody knows, should stand up and let us clap for them also basically. And I request Manoj also to come and take the one of the memento from us before I close the session. Thank you so much. And with that words, wish you all the best, and I close this session. Please do take the lunch before you leave this Patel Chess Institute. Thank you so much.